So good morning everyone. So today, good morning everyone. So today is our last class. So we'll be having a temporary pause in pharmacology. So good morning everyone. Yes, good morning. Yeah, that's great. Mimansa has come with a lot of time. She's ready to sit till 9. That's great. This is a spirit which is always wanted from a student. Yes, beta. Nimita, all the other systems will be covered subsequently. Okay? Everything will be covered. Don't worry about it. Yes. So have a little bit of each subjects. So we have pharma, then we have surgery, we have ENT. You will enjoy the mixture of the flavors of all subjects together. Okay. It's not blurred, beta. If you are seeing it's blurred, just change your phone settings a little bit. I'm also using my phone and seeing e-medicos. It's perfectly fine coming. Okay. It's coming perfectly fine. So today we will be starting with antidepressants, depression, anxiety, bipolar disorders, the remaining psychiatric disease, and if the time allows, opioids. Okay. The remaining portion, anesthesia, will be covered in anesthesia. Okay, first it will be covered in anesthesia, and then when the next term of pharma will come, we will again discuss anesthesia. Okay. Okay, so today we will be starting with, yesterday we completed antipsychotics. So today we will discuss about depression, antidepressant, anti-anxiety, bipolar disorder. All the remaining psychiatric disease we will cover today. Okay. All the remaining psychiatric disease we will cover today. I think, yes. How many pages will be required? I can't guarantee that. You require a lot of pages today. Okay. Yeah. Yeah. See, everything takes time to find a drug for cancer. Human mankind, remember, society is always progressive. Society is from past thousands of years, it's only progressing. We are progressing slowly and slowly. Sooner or later, we'll find the cure for everything. Like we have found the cure of infections. Many of the infections we have now completely cured. Okay. So it takes time. Everything takes time. Okay. But who want to live forever? Don't you think? If you have a limited time, you enjoy a thing more. Hai na? Chalo, let's start. Let's start without wasting any more time. Without going into depression. Let's make a heading, depression. Let's make a heading, depression. Let's make a heading, depression. Now, remember what causes depression. Actually, we don't know. Actually, we don't know what causes depression. Okay. But what is the hypothesis? The hypothesis of depression is, that hypothesis is known as monoaminergic hypothesis. The hypothesis of depression is monoaminergic. Monoamine means certain neurotransmitters. It says that in our brain there is decrease in level of monoamines. Which monoamines? You will write serotonin, norepinephrine, and dopamine. Write this word. I'm adding a word dopamine today. Okay. Okay. So because of this reason, what happens? there is decrease in BDNF level. BDNF stands for brain derived neurotrophic factor. This is the hypothesis of depression. So what is the mechanism of action of antidepressant drug? Now this is important. Now what is the mechanism of action of antidepressant drugs? Okay, yes, 2020 is causing depression. Don't be depressed. Okay, everything has a good angle also. So what causes antidepressant drug? You will write they increase the level of monoamines like serotonin, norepinephrine, or dopamine. So antidepressants, their action is they increase the level of amines in our brain. Now, what will happen? See, suppose this is a neuron, and this neuron has released large amount of now epinephrine, norepinephrine is released. So now what will happen on other neuron? On other neuron, there will be now increase in GPCR receptor density. Okay, there will be increase in receptor density, and now this receptor will function. This receptor will function, which will lead to increased production of BDNF. Please mark it. Which will lead to increase in production of BDNF. BDNF stands for brain derived neurotrophic factor. Okay, brain derived neurotrophic factor. So this is the first slide, beta. This is the first slide of a day. What causes depression? Amine level in our brain reduces, like serotonin, norepinephrine, dopamine. They all are amine, like catecholamine, 5-hydroxytryptamine, another name of serotonin. So they all are amine. Antidepressant drug, they increase the level of amine in our brain. Because of this reason, their receptor will increase, and when receptor will function more, there is increased production of BDNF. BDNF stands for brain derived neurotrophic factor. Okay, now what will happen? This brain derived neurotrophic factor, it increases CFOS. Now this question was asked last year. Gene expression. Please mark it. Last year question. Till now this question wasn't asked, but last year this question came. CFOS gene expression. So BDNF act on which gene? CFOS gene. Which will lead to neurogenesis, excessive neuronal connections, which will lead to neurogenesis. So neurons will sprout, and it will form very good connections with other neurons now, which will form very good connection with other neurons as well. So person will have more intelligence, person will have better mood, etc. Okay, it will form sprouting. Okay, so with the neurogenesis, you will write it leads to neuronal plasticity. Neuronal plasticity will increase. Okay, so in this part, you have to learn two things. First point, what is the mechanism of action of antidepressant? They increase the level of amine in our brain. Due to this, BDNF level increases. BDNF act on CFOS gene, which leads to sprouting of neuron, and better neuronal connections will be made, which overcomes depression. Okay? Okay? GPCR, you know, I hope GPCR. But now there is a point you have to remember, that when you give antidepressant, effect of, I'm using the word AD for antidepressant, comes after 3 to 4 weeks. Do you think that all this thing will occur in one day or one dose? No. Everything takes time. So the effect of antidepressant drug comes after 3 to 4 days. So the question comes, can you use this antidepressant drug for acute treatment of depression or acute treatment of anxiety when the person is having acute attack? The answer is no. You cannot use them in acute attack. The reason is they take time for their action. Okay? It takes time. They take time for their action. So effect of antidepressant drug comes in simple word after 1 month. Remember like this. Okay? Weeks. 4 weeks means 1 day. Okay? Okay? Their effect comes after 1 month. Remember like this. Weeks, beta, weeks. Not days, weeks. I am telling you weeks. Or you will write 1 month. Now it is okay. 1 month. So, hence, antidepressant drug, they are given for chronic treatment only. They are given for chronic treatment or maintenance only. Okay? It is weeks, beta. Okay? Don't ask same question again and again. So my question is, tell me, if a patient comes to you with acute attack of depression, remember in acute attack of depression, person has suicidal tendency or suicidal ideation. Ideas are coming. Can you give antidepressant? Can you give antidepressant to control? No. Remember, for acute depression or suicidal tendencies, the treatment of choice is hence immediate treatment is ECT, electric shock, electroconvulsive therapy. Similarly, in acute anxiety attack, can you give antidepressant? No, their action will come after 3-4 weeks. Give benzodiazepines. I hope you have understood how to manage a patient. Okay? So in acute attack of depression, if a person is having suicidal tendencies, antidepressants will take time, 3 to 4 weeks, 1 month will. So you have to give acute treatment, that is ECT and benzodiazepine. Okay, that's great. So let's talk about first classification of antidepressant. After that, I will tell you how to manage depression. Okay, how to manage depression. Anxiety we will discuss after depression. Okay, so let's talk about now classification of antidepressants. Before writing classification, remember one point, that antidepressant, they increase the level of amines in our brain. Okay, we know those amines. Okay, they increase the level of amines in our brain. Yes, attempt or ideation is same thing. Okay, the person who has ideation will only do an attempt. Okay, now classification of antidepressant. Now these antidepressants are of 3 types. First you will write as reuptake inhibitor. Second you will write MAO inhibitors. And next you will write certain new drugs which will have some different mechanism of action. These new antidepressant drugs are known as atypical antidepressants. I'm using AD word for antidepressant. Okay, I'm using AD word. Okay, yes beta, we give methotrexate along with ECT, yes, to sedate a person. You are absolutely right. Okay, so first let's focus on what is this reuptake inhibitor and MAO inhibitor. Then I will tell you certain new drugs, new antidepressant later on. See, understand this part first. Okay. Suppose, sir, this is a neuron. Okay, write it here only. Leave this line. This is a neuron. Remember, this neuron releases amines like, let's say, norepinephrine. You'll write serotonin, which will act on other neurons. Their receptors are GPCR receptors, okay, which act on other neurons. Now, how the action of norepinephrine and epinephrine gets over? This norepinephrine is reuptaken back. It is known as reuptake. Can we call this transporter as NET? Can we call this transporter as NET? Norepinephrine transporter. And for serotonin, let's call this transporter as SERT. SER stand for serotonin transporter. So let's understand this part, that if you inhibit them, if you inhibit this transporter, the level of norepinephrine and serotonin will increase. Do you agree with this point? So reuptake inhibitors, they inhibit, you'll write below reuptake inhibitor, they inhibit NET and SERT. NET beta stands for norepinephrine transporter. Full form you don't have to write. Serotonin transporter is SERT. Simple. You write SET. Some books write SET, some books write SERT. We will use the term SERT, bigger name. Now, second point. We know that this norepinephrine and serotonin are released from the nerve. Suppose this is norepinephrine and serotonin. Okay. If they have to get released, they must enter into vesicles. Okay. If they will not enter into vesicle, inside the neurons, they will degrade into MAO enzyme. If they will not enter into vesicle, in our cytoplasm and mitochondria, we have one enzyme, MAO enzyme. Okay. MAO, I will tell you the full form. As they are monoamines, let's call that enzyme as monoamine oxidase. So monoamine oxidase will degrade monoamines. So if you will inhibit this enzyme MAO, it will promote the release of norepinephrine and serotonin, because they will not be degraded inside the neuron. Okay. They will not be degraded inside the neuron. Okay. So MAO inhibitor inhibit degradation. Okay. So they will inhibit degradation. MAO inhibitors, they inhibit degradation of degradation of monoamines. So let's talk about first reuptake inhibitors. Among reuptake inhibitor, I will first give you the list of the drugs. Then we will discuss one by one. Can you tell me what this drug will be? SSRI. Selective, we will write full form shortly. Selective serotonin reuptake inhibitor. Serotonin norepinephrine reuptake inhibitor. Only norepinephrine reuptake inhibitor. And lastly, one drug you will write tricyclic antidepressants. Short form TCA. Okay. Short form TCA. Okay. Here there is no role of COMT beta. In depression, there is no role of COMT. COMT we discussed in Parkinson's. In Parkinson's we have a role of MAO, and in depression we have a role of MAO. Okay. I hope you have understood. Okay. TCA stand for tricyclic antidepressant, TCA. Okay. TCA. So reuptake inhibitor, SSRI, SNRI, NRI, TCA. Okay. Now let's start with the first one, which has become the drug of choice for all type of depression, all type of anxiety disorder or neurosis. That drug is SSRI, which has become now drug of choice everywhere. Full form we will write beta. SSRI will be, let's write full form. SSRI. SSRI, let's make a heading. Selective serotonin reuptake inhibitor. Okay. Selective serotonin reuptake inhibitor. Okay. Now let's start with SSRI first. You'll write SSRI. Now they have become drug of choice for depression. They have become now drug of depression. Okay. So if a patient comes, which drug you will start? SSRI. Second, they have also become the drug of choice for all neurotic condition. In neurosis, you will write anxiety disorder. Anxiety disorders. I think we had made a chart, beautiful chart, in the previous class, and we have written. So can you tell me certain anxiety disorder? Can you tell me certain anxiety disorder like generalized anxiety disorder, post-traumatic stress disorder, obsessive compulsive disorder? Remember all those lists? Eating disorders like anorexia and bulimia. Okay, premenstrual tension syndrome. We have written everything. So we know that part. Apart from this, just write two more points. They are also used in the treatment of premature ejaculation. Why? I will tell you shortly. SSRI are also the drug of choice for premature ejaculation. Reason we will discuss shortly. Okay. PTSD is beta, post-traumatic stress disorder. PMTS. We have already written premenstrual tension syndrome. And you will also write it is also given for post-menopausal hot flushes. I will tell you the reason why these two conditions extra we are writing. We will talk about SSRI, then we will come to know. Okay, then we will come to know. Post-traumatic stress disorder. Due to some war or due to some loss, a person becomes depressed. No? Let's say somebody died in family and person becomes depressed. Traumatic stress disorder. Okay. Generalized anxiety disorder, GAD. OCD is obsessive compulsive disorder. Okay. Yes, it is the drug of choice. It is the most preferred drug. Now, let's talk about first what are the different drugs we have among SSRI. The drugs, you can write a mnemonic. FEX, PDF. Okay. First, I'll tell you the name. First is fluoxetine. First is fluoxetine. Second, you will write escitalopram. Citalopram, citralline, paroxetine, depoxetine, and lastly fluvoxamine. Lastly, fluvoxamine. These are the drugs. Yes, you are absolutely right, Soumya Yadav. Because of vasoconstriction, they are given in hot flushes. Yes, you are absolutely right. Okay. Now, drug of choice for hot flushes is OCP, oral contraceptive pills. Santosh Ganpat. Now, this is you have to remember. Okay. Now, let's talk about one by one. Among them, first we will write about fluvoxetine. First point with fluvoxetine is it is the only antidepressant. It is the only antidepressant which has been approved among all antidepressant. It is the only antidepressant approved in people less than 18 years of age, or you will write children. I'm using the word children because this question comes. What is the drug of choice for depression in children? Answer is fluvoxetine. No other drug is approved below 18 years of age. Second point with fluvoxetine is that fluvoxetine, chalo, I will tell you that second point shortly. Let's talk about escitalopram and citalopram. They are the safest and most specific SSRI. They don't interfere here and there. Okay. Second point, you will write that these three drugs, escitalopram, citalopram and sertraline, these three drugs, we will write, are safest drug in heart disease patient. They are the safest drug in heart disease patient. Second question. Think logically and tell me this question has been asked. Which is the only SSRI contraindicated in pregnancy? P for pregnancy, P for paroxetine. The only SSRI contraindicated in pregnancies, paroxetine. It causes cardiac defects. It also causes cleft lip and cleft palate, but you will write cardiac defects. Okay. And the last point with SSRI, we will write that fluvoxamine is the only SSRI not used or not approved for depression. Which is the only SSRI not given in depression, not approved for a depression? Fluvoxamine. Fluvoxamine is only given for OCD or anxiety disorders. Okay. Only given for OCD. Yes, beta, children also go into depression. Yes. Depression is now rampant. It is growing in children. Yes. Okay. Okay. They suffer from depression, children. Yes. Suppose child is having very long-term disease, let's say kidney disease in small age, he may all go into depression. So depression, okay. Now let's talk about the properties of SSRI. SSRI is a very important topic. Okay. All SSRI, remember, you will write all SSRI, they are given oral and once a day. First point. Second point, SSRI, they are metabolized or degraded in our body by CYP2D6. Now please encircle this. This question has been asked. They are metabolized by CYP2D6. Okay. And you will write they are also inhibitor of CYP2D6. While they are getting degraded by CYP2D6, they reduce the activity also. Okay. Now what is the importance of this point? This question comes. There is one more drug which get metabolized by CYP. CYP is beta cytochrome P. There is one drug which is also get metabolized by CYP2D6. Heard about this drug somewhere? Tamoxifen. Heard about tamoxifen? It is considered as a drug of choice for breast cancer, estrogen wala breast cancer. This tamoxifen get converted into active form by CYP2D6. So tell me, if you are combining SSRI with this drug of breast cancer, what will happen to the activity of tamoxifen? Remember, CYP2D6 activity is reduced by SSRI. Hence, can we say SSRI reduce the action of tamoxifen? Okay. So SSRI decrease the action or effect of tamoxifen. This question has been asked. SSRI, they reduce the action of tamoxifen. Yes. Done. Now 2 points. Which is the longest acting SSRI? And which is the shortest acting SSRI? There is a lot of controversy. What I am telling you, follow that only. Longest acting SSRI, fluvoxetine. Why? Because fluvoxetine is an active drug and it acts for 50 hours. Its half-life is 50 hours. This fluvoxetine gets converted into another active form, that is norfluvoxetine. I'm using F word for fluvoxetine. I'm using the word norfluvoxetine. It gets converted into another form, norfluoxetine. It is also an active form which act for 200 hours. Which act for 200 hours. So the longest acting antidepressant overall is which is fluvoxetine. Okay. Yes, you're absolutely right. Shortest SSRI is no doubt in this paroxetine. Please write, this question have been asked, so that is why I am telling you. Now, what is the importance of this paroxetine and fluvoxetine, longest and shortest? I will tell you later on. In our patient, what is the importance of having longest and shortest SSRI? That has a one clinical implication. We will discuss later on. Okay. Now, let's talk about side effects of SSRI. Very commonly asked question. It's a very important part. Side effects of SSRI. So please remember them. And understand them properly. So it's a very important topic, side effects of SSRI. Every year expect one question from this part. Okay. Every year one question comes. Leave better 2-3 pages. Okay. Now let's understand what are the side effects. Okay. First point. First you will write visa. First you will write visa. You will write vivid dreams, insomnia, vivid dream, insomnia, okay, anxiety, okay, anxiety and suicidal tendency. That means increase the risk of suicide. First point, visa. I'll tell you the reason why. Okay. Visa. Why? You will write it is because of excessive increase in serotonin level. It is because of excessive release increase in serotonin level in initial 4 weeks. In initial 4 weeks, that will act on brain, and on brain they stimulate 5-HT2 receptor, and on brain it stimulate 5-HT receptor of serotonin, which leads to vivid dreams, insomnia, increase in suicide in initial 4 weeks. Okay, vivid dreams means psychosis and psychotic symptoms, nightmares, night terrors, etc. Okay, I hope you have understood. Now, don't you think that SSRI, they are increasing anxiety in initial 4 weeks? They are given for the treatment of anxiety, but in initial 4 weeks they are increasing anxiety. So tell me one point. Yes, what happens after 4 weeks? What happens after 4 weeks? This receptor becomes desensitized, and beneficial effect of SSRI comes. I hope you have understood. After 4 weeks, this receptor becomes desensitized, and the beneficial effect of SSRI comes. Yes, serotonin initial increase will lead to suicide. Yes, it is written in our books. So just write this part. Okay. Okay. Now the point is, okay, why suicide? Because of anxiety and vivid dreams. If a person is anxious, person may commit it. Okay. Now tell me, in initial 4 weeks, always combine benzodiazepine for initial 4 weeks. So if you are starting SSRI in your patient in initial 1 month, which drug you will start along with SSRI? Benzodiazepine. Why? Can you tell me why? Because benzodiazepine, I have told you, they are effective in acute anxiety. They have immediate effect. Hence, benzodiazepine for initial 4 weeks are always given with antidepressants like SSRI, because in initial 4 weeks, they may rather increase the symptoms due to over excess of serotonin. Everything should be in balance, not very high, not very less. Things should be in balance. Excess creates problem, deficiency creates a problem. Okay, I hope you have understood. Let's talk about next side effect. Most common side effect of SSRI is nausea and vomiting. Let's see the reason why. Because they stimulate, you know that SSRI are increasing serotonin level. Excess of serotonin stimulate which receptor? 5-HT3 receptor on CTZ area. Remember CTZ area of brain, which is known as vomiting center. This CTZ area has 5-HT3 receptor. Okay, CTZ area. And this is the vomiting center of our brain, which leads to vomiting. Okay. Okay. Next point. Can you tell me a drug which is an antiemetic drug? Ondansetron. It is 5-HT3 antagonist. Heard about ondansetron, everyone? So SSRI, they increase serotonin level. Ondansetron reduces serotonin. It blocks the 5-HT3 receptor in CTZ area. Very good. Let's move ahead. Next side effect. Next side effect. We will write. It causes sexual dysfunction. Let's see. Now this is very important. It is a very characteristic side effect of SSRI, sexual dysfunction. What happens in sexual dysfunction? We will write there will be delayed ejaculation. There will be delayed ejaculation, anorgasmia, and impotence. Impotence is erectile dysfunction. Erectile dysfunction. Let's understand why. Because these SSRI increase serotonin level, and this excess of serotonin act on 5-HT2 receptor. This 5-HT2 receptor causes vasoconstriction in corpus cavernosum. Corpus cavernosum. Hence, because of vasoconstriction in corpus cavernosum, which is penile vessels, it will decrease the blood supply to penile area. If there is decrease in blood supply to the penile area, penile erection will not happen. Okay? Penile erection will not happen. Now, if I make a drug, just think logically. If I make a drug which is an SSRI with 5-HT2 blocker, can you tell me the advantage of this drug? There is a new drug I will tell you, which is an SSRI, but it will not act on 5-HT2. That drug is trazodone, which I will be telling you shortly. And can you tell me a great advantage of trazodone? Trazodone advantage is no sexual dysfunction. We will discuss this trazodone shortly, but I am telling you here so that you can understand this drug. Okay? So that you understand this drug here. Okay? I hope you have understood trazodone. Trazodone is an SSRI, but it acts on which receptor? It inhibits the action of serotonin on this receptor. I hope you have understood. Now, before going further, which SSRI causes maximum sexual dysfunction? Maximum action on penile area is by paroxetine. Sexual dysfunction maximum is seen with which SSRI? Paroxetine. So which paroxetine causes delayed ejaculation? Hence this paroxetine is given for the treatment of premature ejaculation. Because of this side effect of SSRI, we have used this side effect of SSRI to treat one disease. Okay? To treat one disease. That is paroxetine premature ejaculation. I hope you have understood this part. Let's move ahead. Fourth, GIT. In GIT, serotonin increases motility and hence they cause diarrhea and abdominal pain. Okay, diarrhea and abdominal pain. Why? Because, sir, in our GIT, we have 5-HT4 receptor, and 5-HT4 receptor in our GIT causes intestinal contraction. That is why we have made a new class of drug known as prokinetics. Can you tell me what does the word prokinetic means? Pro means increasing, kinetic means motility. These drugs are 5-HT4 agonist. Question of this year NEET exam. These drugs, they end with the word These drugs, they end with the word pride. They end with the word pride. Just write three drugs: Cisapride, Mozapride, Prucalopride. Question came this year in NEET exam. Prucalopride act on which receptor? I will tell you this drug again in GIT. Okay? They end with the word pride. Okay? So why SSRI they cause diarrhea? Because they increase motility by increasing serotonin level. Serotonin act on 5-HT4 receptor in our GIT. Agreed? Last few side effects. You will write last few side effect. You'll write SSRI they cause platelet dysfunction. In platelet dysfunction, you will write they cause thrombocytopenia and bleeding. Thrombocytopenia and bleeding. Can you tell me why? Remember, in our blood, you will not find serotonin. All this serotonin is taken by platelet. All the serotonin in our blood is taken by platelet. Okay, and then this platelet they attach and stop bleeding. Then this platelet they release this serotonin and it causes platelet aggregation. Can we say that this serotonin inside the platelet goes through SERT transporter? So they inhibit uptake of serotonin in platelet. Platelet will not attach to the blood vessel. Bleeding will continue. Bleeding will continue. Okay. 5-HT4 receptor beta increases motility. Agonist will increase motility because serotonin, tonin means increasing tone and motility. Okay. Done. Certain miscellaneous side effect. Miscellaneous, you will write that SSRI they have very mild anticholinergic effect. Question of previous year. Hence they cause dry eyes and dry mouth. They may cause QT prolongation. On heart, you'll write very rare. Very rare. Okay? Very rare they may cause QT prolongation on heart by stimulating serotonin receptors on heart. Okay? By stimulating serotonin receptors on heart. Why platelet dysfunction? Remember, serotonin enters into the platelet by same transporter. Then this platelet releases serotonin, which helps in platelet aggregation and stoppage of bleeding. Okay, stoppage of bleeding. Done? Okay, this completes the side effect of serotonin. I hope you have understood each and every side effect of serotonin, SSRI. They are very commonly asked. Okay? Okay? Chalo, let's talk about now. Let's talk about now next class of drugs. So this was the main drug. Let's talk about now SNRI. SNRI stands for selective. You cannot write, if you don't want to write selective, it will be fine. Serotonin norepinephrine reuptake inhibitor. Okay, so can we say that SNRI is inhibiting both serotonin and norepinephrine reuptake? SSRI was just inhibiting reuptake of serotonin. SNRI is inhibiting reuptake of both. Can we say it will be a better drug? It will be a better drug as compared to SSRI? Yes. You will write the uses of SNRI is SNRI, they are used in resistant cases of SSRI. If a person is not responding to SSRI, then we start SNRI. I hope you have understood. Okay. I hope you have understood. Good. Let's write what are the names. Very simple. Very simple. Write one mnemonic. Very difficult MD. Very difficult MD. These four names are very important for you. Please write. The names are very frequently asked from you. Okay. What are the names of SNRI? Very difficult MD. You'll write vanilla vaccine. We have made one molecule DES, vanilla vaccine, DES form. Milnacipran. Milnacipran. Okay. Just a moment. Milnacipran. I'm writing. Milnacipran. And the last drug, very important for you, many times asked, duloxetine. Beta 5-HT4 agonist. Ramu, 5 agonist, prokinetic. I have written correct, beta. Okay. Very difficult MD. Okay. So make a mnemonic. You can write the mnemonic yourself. Done? Done? Very difficult MD. Now, before going further, just write milnacipran is only given for the treatment of fibromyalgia. In psychiatric disease, patient has excessive sensation, excessive perception of pain. Pain, a small pain appears very big. That's fibromyalgia. Duloxetine, very important for you. Duloxetine is given for the treatment of fibromyalgia. It is given for diabetic neuropathy. But the drug of choice for diabetic neuropathy, I have told you, was pregabalin. Remember pregabalin? And lastly, it is the drug of choice and the only drug for a condition, stress urinary incontinence. Stress urinary incontinence. Now let's understand what we have written here. Okay, let's understand what we have written here. Just write the drug of choice is pregabalin in diabetic neuropathy. But duloxetine can also be used. It is also an approved drug. Okay. Now what do you mean by the word pregabalin? Now what do you mean by the word stress urinary incontinence? I have told you one overactive bladder. है ना? I'm telling you one more cause of urinary incontinence. If you remember, this is urinary bladder. And we know that below this urinary bladder, we have IUS. Remember internal urethric sphincter? And internal urethric sphincter, if you remember, has alpha 1A receptor, which generally close this sphincter. Okay. Now, what happens in stress urinary incontinence? You have seen certain movies. When there is sudden fear or overexcitement, there is sudden passage of urine. Right? So this is stress urinary incontinence. Okay. Now, why we give duloxetine? Because duloxetine increases norepinephrine level. Okay. Norepinephrine act on alpha 1A and close IUS. It closes IUS. Stress urinary incontinence occur because of sudden opening of IUS. Stress urinary incontinence occurs because of sudden opening of IUS, the person in excitement or something like this passes urine. Norepinephrine closes IUS. So why we give duloxetine? Duloxetine increases the level of serotonin and norepinephrine. Norepinephrine will act on alpha receptors and close this sphincter. Okay? Okay? I hope you have understood. Let's talk about two lines about these drugs. You'll write shortest acting is venlafaxine. What is the importance? I will tell you. Okay. In pregnancy, all SNRI are contraindicated. In pregnancy, all SNRI were contraindicated, and the only SSRI was contraindicated was paroxetine. Okay. Same reason, cardiac defects. Lastly, side effect. First point, same like SSRI. We already know this part. But you will write that this venlafaxine, we know that it has one peculiar side effect. We know that venlafaxine increases norepinephrine level. And norepinephrine causes vasoconstriction by acting on alpha receptor. Hence it causes sustained diastolic. Tell me, hypertension or hypotension? Hypertension or hypotension? Increase in BP or decrease in BP? Hypertension. Why? Because norepinephrine causes vasoconstriction because of alpha receptor. Norepinephrine doesn't have action on beta receptors. Okay? Okay? So remember this part. SNRI. Next drug we will write only one drug, NRI. NRI stands for norepinephrine reuptake inhibitor. Do you agree with this point? Norepinephrine reuptake inhibitor. Only one drug, sir. The only drug we have is atomoxetine. Only one drug. Atomoxetine. Use. See, you are saying A word is coming and T word is coming. Okay? So write A for. It is given for the treatment of ADHD. I hope you remember what was ADHD. Attention deficit hyperkinetic disorder. And T word is coming. T for you can write Tourette syndrome. If these two things are occurring together, it is a drug of choice. Okay? Okay? It is a drug of choice. Very good. Tic disorder. Yes. A and T. I hope you can remember this. Atomoxetine. A and T. Okay? Now, can you tell me what was the drug of choice for ADHD I have told you? Okay? The drug of choice for ADHD, if you remember, I've told you amphetamines. Yes, you're absolutely right. The advantage of atomoxetine is it is not a CNS stimulant like amphetamine. It is not a addictive drug like amphetamine. CNS stimulant means it was causing seizures, okay? Okay. So this is the advantage of atomoxetine. Last reuptake inhibitor. Last reuptake inhibitor is TCA. Remember TCA? Tricyclic antidepressant. 50 years back, they were the drug of choice, but now they are very rarely used. They are very dangerous drug. So wherever the word TCA comes into your mind, remember they are dangerous. TCA are dangerous. Okay, have this idea in your mind. Okay, we are coming to beta bupropion. They all are atypical antidepressants. Okay, TCA. We will discuss all antidepressant. You will say it, in the end, you will tell to me, sir, please don't tell more drugs about antidepressant. I will tell you each and every drug. Don't worry about that. The drugs which are very important, first have focus on that. Tricyclic antidepressants. Okay. Now, again, tricyclic antidepressant, we know they are reuptake inhibitors. First, let's write their names. Tricyclic antidepressants, either they are norepinephrine and serotonin reuptake inhibitor, okay, or they are predominantly norepinephrine, less of serotonin reuptake inhibitor. So that is predominant norepinephrine reuptake inhibitor. Okay. Either they inhibit reuptake of both, or they will predominantly inhibit the reuptake of norepinephrine. Okay. Okay. Safety, Anjali, because SNRI, they have a lot of extra side effect. Okay. Let's write their names. Easy to remember. Write a mnemonic. ITC, DAD. ITC, DAD. Here you will write ITC, DAD. I for, you will write imipramine, trimipramine, clomipramine. These names are very commonly asked. And you can see they all are ending with the word pramine. Okay, they all are ending with the word pramine. Here you will write doxepin, amitriptyline, and dothepin. Okay, in one go you will not able to remember. You have to read them 2-3 times. Okay, 2-3 times. Okay, if platelets are not aggregating, they may go into spleen also. Redundant platelets, Sabira, they go into spleen and they are reuptaken. Okay. Okay, you want to see the slide of amphetamine. Okay, just have this slide again. Okay, so I'm showing you this slide. Okay, so just see this slide. Now I'm coming back to tricyclic antidepressant. Okay, I'm coming back to now tricyclic antidepressant. Done? Chalo. Here you will write Dr. Mann. Okay, Dr. Mann. So you will write des-imipramine, reboxetine, meproteline, yes, Babni Shankar Sahu, you know this part. Doxepin, I have told you in insomnia. You remember, that's great. I will tell you that point again. Don't worry. Nortriptyline. Okay. So a little bit, these are very old drug, very confusing names. Have them as a reference first. Try to remember. Okay. When you're solving MCQ, try to remember. Now one point I want to ask you. One point I want to tell you, that encircle this imipramine. The active form of imipramine is des-imipramine. Okay. Similarly, the active form of amitriptyline is nortriptyline. Just write these two additional points. The active form of amitriptyline is nortriptyline. Active form of imipramine is desimipramine, and we have made them as separate drug. And we have made as a separate drug. Done? Let's talk about now them. Okay. You will write earlier, some 20 to 30 years back, tricyclic antidepressants were the drug of choice everywhere. But now the drug of choice have become SSRI. Let's see the reason why we are now not giving tricyclic antidepressant commonly. So we will write, you'll write, if you talk about TCA uses, you will write, now they are not drug of choice. Now they are not a drug of choice. Reason is because they are narrow therapeutic index drug. What does it mean? Narrow means very low safety margin. Therapeutic index means safety margin. So they are very dangerous drug. If you little bit increase the dose, it will lead to toxicity. So they are very dangerous. And hence they require TDM. Remember TDM word? Therapeutic drug monitoring. They require therapeutic drug monitoring. So here only we will write now that SSRI and SNRI, they are very safe drug. Or you will write wide therapeutic index. And do they require monitoring? No monitoring. That is why I have told you that SSRI and SNRI, because of their safety reason, they are the drug of choice. In depression, because of the safety reason, we have made them as a drug of choice. Okay, done. So let's talk about uses of TCA and side effect of TCA. Last point, uses of TCA. So are they drug of choice anywhere? No, they are not a drug of choice anywhere. They are rather second line drug. Okay, so they are rather now second line drug. Let's talk about the uses of TCA. Uses of TCA. Write a mnemonic for it. Denims. Write a mnemonic. Denims. First use of TCA. Depression. But can you tell me what is the drug of choice now for depression? SSRI. Do you agree with this point? So TCA are not the drug of choice. Second, enuresis or bedwetting in children. For this we use one drug, imipramine. I will tell you the reason why shortly. Which tricyclic antidepressant is given in children to control bedwetting or enuresis is imipramine. But is imipramine the drug of choice? No. Drug of choice has become desmopressin. Drug of choice for nocturnal enuresis has become, I think we have already discussed, desmopressin. Third, you will write neuropathic pain. And I have told you about neuropathic pain, pregabalin and gabapentin. In trigeminal neuralgia, you can use carbamazepine. Then migraine prophylaxis. There are two anti-tricyclic antidepressants which have been approved for migraine prophylaxis because they relieve pain. One is amitriptyline and nortriptyline. But what is the drug of choice for migraine prophylaxis? The drug of choice for migraine prophylaxis is propranolol. Okay, the drug of choice for migraine prophylaxis is propranolol. Okay, propranolol. Lastly, smoking cessation. And I told you one drug which is a second line drug for smoking cessation, again nortriptyline. I'm using the short form for nortriptyline, smoking cessation. Okay, smoking cessation. Again, it is not the first line drug. First line drug I have told you three: nicotine, very bad; nicotine, varenicline, and bupropion. Okay, see your notes, you will find it. So they are not a drug of choice anywhere. They are now second line drug because of safety reason. Okay, for acute attack of migraine beta, we give generally triptan, sumatriptan and all. Last point you will write that clomipramine, one question which comes, has been approved for OCD. Okay, OCD. OCD is obsessive compulsive disorder. Okay, let's talk about adverse effect of TCA, tricyclic antidepressant. Side effect of tricyclic antidepressant. Very simple. Very simple. Side effect is, first we will write same like SSRI. Same like SSRI. We know SSRI. Why? What are their causes? Second point. Why they are dangerous? Because TCA, they block many receptors in our body. Almost any receptor in our body is blocked. Let's talk about this very interesting part. Okay. TCA, they block many receptors in our body. If I say histaminic receptor, so you will write they have anti-histaminic property. Question comes. Because of this reason, they are highly sedative. So remember, if you block histamine receptor, it causes sedation. We will discuss in histamine. And which TCA causes maximum antihistaminic property among tricyclic antidepressant is doxepin. And if you remember, I have told you that doxepin has been approved for the treatment of insomnia. This doxepin has been approved for the treatment of insomnia. Good? Very good. Second point, they have anticholinergic property, or you will write atropine-like property. Atropine-like property. Can you tell me atropine causes dry eyes or dry mouth? Dry eyes and dry mouth. It causes urinary retention. Can you tell me why? Because it relaxes detrusor muscles. It relaxes detrusor muscle. Remember, all secretions of the body will reduce. Salivation, lacrimation, urination, है ना? Lastly, in eyes, atropine causes mydriasis. Atropine causes mydriasis. Very good. Which drug causes maximum? Imipramine. Question has been asked. Which drug has maximum anticholinergic property? Imipramine. So can we say imipramine causes maximum urinary retention? Because imipramine causes maximum urinary retention, it is given for the treatment of bedwetting or enuresis. Because of this reason, Imipramine is given for the treatment of bedwetting or passage of urine while sleeping in small children. Okay, yes, that poem you remember. That's great. That's great. Next point. Next point. They have alpha blocking property. Because of this reason, tricyclic antidepressants, they cause hypotension. They cause hypotension. Next, they block sodium channel. Because they block sodium channel, they have local anesthetic property. They will suppress the conduction of nerve. That is why they were given in neuropathic pain. And similarly, you will write, they block sodium and potassium channel on heart. They block sodium and potassium channel on heart. They are blocking everything. You are seeing they are blocking everything. And you must remember one point. Any drug that blocks potassium channel on heart, any drug that blocks potassium channel on heart will lead to, any drug that blocks potassium channel on heart will lead to increase in QT interval on ECG. What is the reason behind it? We will discuss in CVS, cardiovascular system. And any drug that increases QT interval may cause one arrhythmia. That arrhythmia is known as Torsades de Pointes. That arrhythmia is Torsades de Pointes. Very good. You have heard in, है ना? Torsades de Pointes. Now, there is one class of anti-arrhythmic drug. There is one class of anti-arrhythmic drug which also blocks sodium and potassium channel. It is similar to class 1A. I will tell you in anti-arrhythmic chapter, class 1A or quinidine-like arrhythmia. So, tricyclic antidepressants, they cause which type of arrhythmia? Tricyclic antidepressants, they cause sodium and potassium channel blockage on heart. There is one anti-arrhythmic drug known as class 1A that also blocks sodium and potassium channel on heart. So tricyclic antidepressant, they cause quinidine-like arrhythmia. Just write this word, okay? One question comes. Should we combine quinidine with a tricyclic antidepressant? We don't combine quinidine with tricyclic antidepressant. They increase the risk of arrhythmia. And the last point with TCA, among their side effects is that TCA and all antidepressants, they increase the level of amines in brain, like serotonin, dopamine, etc. And all these drugs, they increase the risk of seizures. Remember, all antidepressant drug, they increase the risk of seizures in our body. But which drug causes maximum? You will write tricyclic antidepressants, they cause maximum seizure, and among tricyclic antidepressant, maximum seizure is by clomipramine. Question which has been asked. And you will write one more drug, bupropion, which I will be telling you in atypical. Which antidepressant drug causes minimum seizure? Can you tell me which antidepressant was safest? Just which antidepressant was safest? I told you. Which was the safest antidepressant? Can we say SSRI were the safest? So minimum risk of seizures is by which antidepressant? SSRI. Okay, SSRI, minimum risk of seizures. Okay, minimum risk of seizures. Okay, I'm giving you the break. Just write the last point, then I am giving you the break. Okay, just write the last point. TCA poisoning. This is the last point. Now you'll write the drug of choice for the treatment of tricyclic antidepressant poisoning is sodium bicarbonate to promote their excretion. The drug of choice for TCA poisoning is sodium bicarbonate. And if there is atropine-like features, add physostigmine. I hope you remember physostigmine. Just write this last point. This finishes our main reuptake inhibitors. Okay. This completes our reuptake inhibitor and majority of depression. Okay. So we are taking just 2 minutes break. So as today is our last class, I cannot deny you. Okay. So let's take a 2 minutes break. No problem. Sit there where you are sitting. Relax. Have deep breaths. Yes, absolutely right. Vutarthi, yes. Same reason. Sodium bicarbonate. Okay. So I hope you all are ready again. Okay, you're ready? Chalo. Now, treatment of depression. If a patient of depression comes to you with sad mood, nihilistic attitude, worthlessness, hopelessness, helplessness, all these are the symptoms, you will start with SSRI. With benzodiazepine. Can you tell me why we are giving benzodiazepine? Benzodiazepine for only 4 weeks. Benzodiazepine only for 4 weeks. I will show you the slides of SSRI side effect later on. Okay. Then continue. Okay. Continue for more than 8 weeks. Okay. Continue for more than 8 weeks. At least 8 weeks we have to give SSRI. And after 8 weeks, see, if there is good response, yes, the patient is saying, yes, now I am out of depression. Continue for at least 12 months. So that means we give treatment of depression SSRI for 1 year. Easy. And we will assess the effect after 8 weeks only. Before 8 weeks, we cannot assess the effect. We will assess how much symptoms are improving after 8 weeks. If there is no response, change to SNRI. You know why? And then continue for 12 months. Okay? Continue for 12 months. After 12 months, now the question which came in your exam, why I'm telling you this part. After 12 months, gradually taper off the dose. And you will write never stop antidepressant suddenly. Never stop antidepressant suddenly. Okay. Otherwise, it will lead to a syndrome known as drug discontinuation syndrome. This question has been asked from is been continuously asked from past 2 years. Okay, last year question came in AIMS exam, 2019 question of AIMS exam. What is drug discontinuation syndrome? Let's understand this part. Let's understand this part. What is this? Is the treatment of depression I have told you. Okay, treatment of depression I have told you. Okay, now let's see what is drug discontinuation syndrome. This is a very important part, many times asked. Okay, now yes, benzodiazepine is also tapered away. Now drug discontinuation syndrome, we will write it is rebound. Rebound means excessive insomnia, anxiety, and even suicidal tendencies. Even suicidal tendencies due to sudden stoppage of antidepressant. Due to sudden stoppage of antidepressant. I hope you have understood. As the term implies, from the name you can easily assess what is drug discontinuation syndrome. Okay. Now tell me, it is not seen with drug discontinuation syndrome is not seen in, maximum seen with now tell me, drug discontinuation syndrome is not seen with a drug. Tell me the reason for it. Fluoxetine. And it is maximum seen with one SSRI, paroxetine. And it is maximum seen with one SNRI, venlafaxine. Tell me the reason for it. Tell me the reason for it. This question was asked 2 years before, and venlafaxine was asked previous year in AIMS exam. Yes, you are absolutely right. The longest acting antidepressant was fluoxetine, 250 hours. It is the shortest SSRI and it is the shortest SNRI. Okay, so even after stoppage of fluoxetine, it will continue to produce effect. So drug discontinuation syndrome is not seen with one antidepressant, that is fluoxetine, and it is maximum seen with paroxetine and venlafaxine. They are very commonly asked question. You're absolutely right. You all are absolutely right. Done. Let's talk about now other antidepressant. Okay. So let's talk about now other antidepressants. So now you know how to treat depression also. Let's talk about now MAO inhibitors. Make a heading MAO inhibitors. Less commonly asked nowadays. Okay. First point, what is MAO? We know the full form of MAO, monoamine oxidase. Monoamine oxidase or MAO, it is a mitochondrial enzyme and it degrades all amines, monoamines. Tell me certain monoamines. Can we write catecholamines? They are ending with the word amine. And you know 3 catecholamines: norepinephrine, epinephrine, dopamine. Second, serotonin, because another name of serotonin is 5-hydroxytryptamine. Tryptamine. Can we write histamine? Again, amine word is coming. And certain food products. One chemical present in cheese. With cheese? Tyramine. Amphetamine. They all are ending with the word amine. You don't have to cram it. You just have to identify amine word is coming. Serotonin is also 5-hydroxytryptamine. So they all are. 5-hydroxytryptamine is another name. Okay, I'll write it for you. 5-hydroxytryptamine. Again, amine word is coming. So it degrades following. Now, we will write that this MAO inhibitors are of 3 types. But before that, you will write that this MAO enzyme is of 2 types. MAO A, MAO B. MAO A is present everywhere, all sites. MAO B is only present in brain. I hope you can remember this point. MAO A is present in whole body, brain, liver, kidney, everywhere it is present. But MAO B is only present in brain. And MAO A degrades all amine. MAO A degrades all amine, while MAO B degrades only dopamine. MAO B degrades only dopamine. Do you agree with this point? So let's see what are the drugs we have among MAO inhibitors. Okay. What are the drugs we have among MAO inhibitors? We'll make a mnemonic for it. We have 3 drugs among MAO inhibitors. Nowadays, very less commonly asked. Okay, less commonly asked. So we will make only one chart for it. Write 3 drugs. Okay. First is irreversible plus non-selective MAO inhibitors. Can you tell me what is non-selective? Non-selective means that they will inhibit MAO A as well as MAO B. Non-selective means that they will be MAO A and MAO B and they both are inhibiting irreversible. Now remember, next word. Next is REMA. This is known as REMA. Reversible inhibitor of MAO A. And lastly, selective MAO B inhibitor. How to remember this? You can see first drug is inhibiting both MAO A and MAO B. Second is only inhibiting MAO A. And the third is only inhibiting MAO B. Okay? Now remember, any drug which inhibit an enzyme irreversibly is known as hit and run drug. Any drug which inhibit an enzyme irreversibly is known as hit and run drug. Okay? Because now this enzyme is permanently dead. You have to make a new enzyme now. Okay? So let's write their names first. Very easy to remember. Here you will write pint. Okay? Pint. P for phenelzine. Isocarboxazid. nialamide and trenyl cypromine. Now you can afford to forget their names because nowadays they are not used very commonly, but you will find old MCQ which will be asking their names. So those MCQ are very old. You can forget that. You don't have to remember. What you have to remember is their name because these are used nowadays. Moclobemide. You have to remember this name. Moclobemide and chlorigylene. Moclobemide, chlorgylene. Selective. Can you tell me these drugs were also given in Parkinson disease? They are also given in depression. I hope you remember their name. Salicyline and rasagiline. Remember their name? Salicyline and rasagiline. We discussed that thing in? Yes, you're absolutely right. Okay. Nowadays we don't use these drugs. No. Okay. Because they cause various fatal drug and food interaction. They cause various dangerous or fatal drug interaction. Patient may die. Hence nowadays we prefer to use this drug or this drug. Okay. Irreversible are nowadays not used because their drug interaction is very dangerous. So let's talk about where they are used. They are given in depression and phobia. Okay. Where they are given, use depression. Now question comes, which antidepressant drug has been made as a transdermal patch? It is available as a transdermal patch. Salicyline patch is available as a transdermal patch for the treatment of depression. They were also used in Parkinson disease, but in depression they are also used. Okay. So let's talk about their fatal drug interactions. First, I think I have already told you. With tyramine, they cause cheese reaction. With the tyramine, they cause cheese reaction. Please refer to cheese reaction in ANS topic, autonomic nervous system. Okay, autonomic nervous system topic. Okay. Second, with levodopa, amphetamine and ephedrine. Ephedrine was nasal decongestant, oral nasal decongestant, cold remedy, है ना? They are very commonly used drug, cold remedy. Normally levodopa was causing hypotension, I told you, but in excessive dose it causes hypertensive crisis. Hypertensive crisis. Last point, very commonly asked question. This point you will remember, that never combine MAO inhibitors with reuptake inhibitors. Never combine MAO inhibitor with a reuptake inhibitor. Reason, they will lead to serotonin syndrome. What is serotonin syndrome? I will tell you later on. It's a fatal side effect, very dangerous side effect, because reuptake inhibitor are increasing the level of serotonin. MAO inhibitor are also increasing the level of serotonin. They both together can increase the serotonin levels drastically. Because of this reason, there should be always a gap between these two. There should be always a gap. This gap is also known as wash-off period. Wash-off means let the effect of that drug gets over. So always there should be a gap between the use of MAO inhibitor and reuptake inhibitor. Now the question comes, what should be the gap? You'll write that MAO inhibitors and SNRI, there should be a gap of 1 week. MAO inhibitor and SSRI, there should be a gap of 2 weeks, except fluvoxetine. Can you tell me, fluvoxetine, I have told you, was the longest acting SSRI? 240 hours, है something like this. So the gap should be less or more? The gap should be more. The gap should be of 5 weeks. Yes, organophosphates are also hit and run drug. Yes, you're absolutely right. The gap should be of 5 weeks. Okay? Remember, this question comes. Last point in depression we will discuss is atypical antidepressants. Atypical antidepressants. Okay? Yes, more gap. You are absolutely right. Longest gap is between fluvoxetine and MAO inhibitor. Longest gap. Okay? Longest gap. So you know the names of SNRI, you know the names of SSRI. Okay? If I will ask you MAO inhibitor and venlafaxine, 1 week. Venlafaxine is SNRI. This question comes. Let's talk about last point in depression, last drugs in depression, that is atypical antidepressants. Some new mechanism of action. Atypical antidepressants. Yes, beta, MAO B inhibitors also causes serotonin syndrome. In high dose, they become non-selective actually. Okay, but lesser as compared to irreversible, lesser. Yes, you are absolutely. Atypical antidepressant. Let's talk about atypical antidepressant. First one. You'll write serotonin. You'll write the short form as first SARI. SARI is serotonin antagonist and reuptake inhibitor. So they will have some different mechanism of action. Okay, serotonin antagonist and reuptake inhibitor. First point, what are the drug names? The drugs are trazodone and nifazodone. Trazodone, or you can use beta Devjani Roy, you can use both words. You can use fluoxetine also, you can use floxetine also. Both names are used. Okay, both names are used. Now what does it mean? Reuptake inhibitor means that they are SSRI. So what is their mechanism of action? that they are SSRI. Okay. Second point you will write, they are serotonin receptor blocker, 5-HT2 antagonist plus SSRI. I hope you have understood. Just write one more point. They are also alpha blocker. One additional point I have told you, one extra point. So what is expected from you? Serotonin antagonist and serotonin reuptake inhibitor. This point. Great advantage. The great advantage of using trazodone is no erectile dysfunction, or you will write impotence. I have already told you this point earlier. Side effect, priapism, rather prolong penile erection. So the patient will become your permanent patient. He will tell you, Doctor Saab, my life is very colorful now. Forget about depression. I'm enjoying my life. Because of this reason, trazodone use. Trazodone is used as a drug of choice for depression with impotence. Okay. So what is the use of trazodone? Depression with impotence. Okay. So at least as a doctor, we have benefited one patient. Instead of treating his depression, at least we have treated or made his sexual life colorful. Next point. Okay. So he will say that you are the greatest doctor on this earth. Now depression is a very small thing for me. Next point, we will write next drug. So this is trazodone, important for you. Okay. Let's talk about second class of drug. Tetracyclic antidepressant. Okay. वैसे ही लॉकडाउन है. To all the singles who are in lockdown, very difficult to survive, है ना? Very difficult to survive 2 months of lockdown without your partner, है ना? Don't worry, don't take trazodone. Don't take trazodone. Okay. Now let's talk about tetracyclic antidepressant. 2 drugs I will tell you. First, you'll write first drug, metazapine and mianserine. Metazapine and mianserine. Oh, that's great. Now, these drugs are known as, what is their mechanism of action? These drugs are known as NASA. Okay, I'll write the noradrenergic and specific serotonin antagonist. Noradrenergic. Okay, Gaurav is still single. Don't worry, I have a best wishes for you. Soon you will get a good partner. Now, NASA. Noradrenergic and specific serotonin antagonist. Let's understand this part. What does it mean? Mechanism of action. It will increase the release of norepinephrine. Reason? You'll write because it is an alpha 2 blocker. I hope you remember presynaptic autoreceptor like clonidine. Clonidine was stimulating alpha 2. It was applying a brake. Norepinephrine was not releasing. If you block alpha 2, there will be more release. It is opposite of clonidine. Okay? It is opposite of clonidine. Okay? Now, specific serotonin antagonist is it blocks serotonin receptors 5-HT2, 5-HT3. It blocks all serotonin receptors. It blocks all serotonin receptors. Now tell me one point. As it is blocking 5-HT2, will it cause impotency? Like trazodone, no. Sexual dysfunction. So same like trazodone, it is causing 5-HT3 blocker. Can you tell me which side effect will not be seen? 5-HT3 CTZ area, tell me. Tell me, it will not produce any nausea and vomiting. I hope you remember nausea and vomiting. So it blocks all serotonin receptors. Great. One last advantage. It has antihistaminic property. It blocks histaminic receptor. Hence, it causes sedation. Hence, it is used for depression with insomnia. Mirtazapine and mianserine are given for depression with insomnia. Yes, no nausea and vomiting. That's great. This question has been asked. This question has been asked. This question has been asked. Okay. So this was the first tetracyclic antidepressant, mianserine and mirtazapine. Next tetracyclic antidepressant is amoxapine. Very commonly asked question. Next tetracyclic antidepressant is amoxapine. You'll write amoxapine is the only antidepressant that blocks dopamine receptor D2. The only antidepressant which blocks dopamine receptor is amoxapine. So can you tell me which antidepressant drug has antipsychotic property like haloperidol? Which antidepressant has antipsychotic property? Remember dopamine, haloperidol, amoxapine. Can you tell me, this question has been asked, please mark it. Which antidepressant drug like haloperidol or antipsychotic drug causes Parkinson's disease? And I hope you remember the short form EPS. Extrapyramidal symptom and prolactin release is again amoxapine. Reason? It blocks dopamine receptor. Yes, it increases GIT motility. Yes, but that is not. So I hope you have understood this part. Remember mesocortical, mesolimbic area, haloperidol we discussed yesterday. Other drugs. Third drug. Yes, this is a question very frequently asked. Next, after tetracyclic antidepressant, you'll write bupropion. Very important drug. Bupropion is NDRI. NDRI is norepinephrine, dopamine, reuptake inhibitor. Remember this drug, bupropion? Very good. Beta, if you remember, I'll repeat alpha block. Okay, don't worry. I have told you that on our nerves, you have alpha 2 receptor. And if you stimulate alpha 2 receptor, norepinephrine is not released. Can you tell me that drug that was stimulating alpha 2 receptor, inhibiting norepinephrine release? Central sympatholytic, clonidine. But if I'll say you that if you block alpha 2 by mirtazapine, mianserine, there will be more release of norepinephrine. There will be more release of norepinephrine. So alpha 2 blocker, they increase the release of norepinephrine by blocking alpha 2. Clonidine stimulate alpha 2 receptor, inhibit the release of norepinephrine. They are presynaptic autoreceptor. I hope you remember that part. Okay. So let's come to now bupropion. Okay. Bupropion, very important drug for you. Just write 2-3 point uses. Bupropion is used in depression. Bupropion has been approved. I think I have already told you, anti-obesity drug. And bupropion, very commonly asked, is also approved as an smoking cessation drug. And recently it has been approved for ADHD. Okay. Recently it has been approved for ADHD. Okay. They are very commonly asked question. Yes. Class is still 3. Side effect, maximum seizures. Maximum seizures. Okay, I will repeat beta again later on. Let's continue. Next. Don't confuse bupropion with this drug. We very commonly confuse this drug bupropion with buspirone. Buspirone is 5-HT 1A partial agonist. Okay, you can afford to forget partial word, no problem. Just remember A. 2A. 1HT 5HT 1A partial agonist. Use. 2A are coming. It is an anti-anxiety drug. It is not an anti-smoking drug. It is used for generalized anxiety disorder. Generalized anxiety disorder. We will come to buspirone shortly. We will come to buspirone shortly. Okay. Again, you need a break. No break for a moment. Let me finish it. Let me finish depression and anxiety. Then I'll give you a break. Okay. For fifth drug, vortioxetine, new drugs, and vilazodone. They are SSRI with 5HT 1A agonist. 5HT 1A agonist. Last drug in depression, Amyneptin and tianeptin. Now your KD Tripathi, mention them as reuptake enhancers. Instead of SSRI, write SSRE. Amyneptin and tianeptin, they are rather opposite drug. They are reuptake enhancer. Use depression, antidepressant. You don't have to go into the detail of amyneptin and tianeptin. Okay, you don't have to go into the detail of amyneptin and tianeptin. No one will ask you. Okay. They are opposite drug of SSRI, still used in depression. So finally, it ends with a note that we know nothing about depression, why it occurs. Everything is a hypothesis. Okay, so this completes depression. Okay, this completes depression. If you don't know how a disease occurs, what is the actual treatment of a disease, there you have to learn multiple drugs, because we don't know what causes depression. Yeah, content is yes. Okay. Okay. A very small topic, anxiety. Depression is over. Anxiety. Most things we have already discussed about anxiety. Okay, write 3 points about anxiety. That will finish anxiety. Okay. Now, first point with anxiety. Tell me, what is this anxiety? Tell me what type of anxiety it is. This is your anxiety level increasing. You are having an exam tomorrow, or you are having a stage performance. After your exam or stage performance, your anxiety level reduced. Can you tell me what anxiety it is? Tomorrow you have an exam, or you have some performance, but after that is over, your anxiety level reduces. This anxiety is known as performance anxiety. And this could be a normal thing. Treatment. Drug of choice. Beta blockers, propranolol. 40 milligrams. Okay. So this is normal. Let's talk about second point, anxiety disorder. Or you will write neurosis. Here what happens, sir? Anxiety never reduces. A person always remains anxious. Okay. Let's see the treatment of this anxiety disorder or neurosis. Yes, situational or performance. Now, if the patient comes to you with if the patient comes to you with acute attack of anxiety, give the drugs benzodiazepine. Give the drug benzodiazepine. Okay. Mechanism of action. They increase GABA activity. Okay. And decrease in GABA decreases anxiety. Increase in GABA reduces anxiety. Drugs, D-Cola. Diazepam, chlordiazepoxide, oxazepam, lorazepam, and alprazolam. We have already discussed them. Okay. Yes, we already know them. Okay. Okay. Next point. Disadvantage. They cause addiction and cognitive impairment like memory loss, intelligence. Because of this reason, never for chronic treatment. Benzodiazepines are never given for long-term treatment of anxiety. Okay. They are never given for long-term treatment of anxiety because they are highly addictive drugs. They cause memory loss. So let's talk about chronic treatment of anxiety. Or maintenance for anxiety. Okay. You'll write the drug of choice is SSRI. The drug of choice is SSRI. Another drug which is approved, venlafaxine. Which SNRI has been approved? Venlafaxine. Venlafaxine. And last drug is buspirone. Remember buspirone? Buspirone. Okay. Buspirone. Now, all types of neurosis or anxiety disorder like generalized anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorder, we know. Buspirone only for GAD. GAD stands for generalized anxiety disorder. Okay. Let's see their mechanism. Last point, what is the mechanism? Okay. You'll write they increase serotonin. Okay. And increase in serotonin in initial 4 weeks increases anxiety. Increases anxiety. But after 4 weeks, you'll write chronic treatment. It leads to desensitization of receptors. Receptors now will stop responding. And now the effect will come. Now the effect will come. So can we say that serotonin increases anxiety in initial 4 weeks? Serotonin increases anxiety in initial 4 weeks, but when their effect will come? Their effect will come after 4 weeks. That is why they are given for maintenance or chronic treatment of anxiety. SSRI are the drug of choice. Okay, buspirone. I have written correct, beta. It is buspirone. I have written correct. BUS. Buspirone, है ना, bus. Can you use SSRI for acute attack of anxiety? Can you use SSRI for acute attack of anxiety? The answer is no. You cannot use. You cannot use. Okay? Because for acute attack, they are not effective. Their effect comes after 4 weeks. Done? This completes anxiety. Last part is bipolar disease. So that will test all your knowledge. It connects both. It has both mania and it has both depression. Everything is there. Okay. So you need a 2 minutes break or no? You need 2 minutes break. Chalo. Again, Alpaviram, 2 minutes break. And we will discuss the last psychiatric disease and one drug we will discuss in very great detail. That is your lithium. So let's talk about bipolar disorder. Beta, no lunch break. No lunch break. There is no scope for lunch break today. Today is our last class. Let me finish the things. Tomorrow you have a day off. You can have a lot of lunch. Okay. So 2 minutes we are having a break. Okay. Okay. Grab your lunch in your hand. From one hand eat your lunch and from one hand write. Okay. And no one can see you what you are eating, so it's perfectly fine. I will repeat everything in last, okay? We will repeat everything in last. Okay, you want ice creams. Okay, everyone ice cream. Everyone want ice cream. Everyone scream for ice cream. We know that. Okay, chal. Ho gaya 2 minutes. Let's come to now excitable and depressive state. I know you are excitable. You are very excitable, but somehow you have to study. You are depressed also. So, Gautam Buddha has said. What Gautam Buddha has said? Gautam Buddha has said that always follow the path of moderation. Never become too excited in your life. Never becomes too sad in your life. So always follow the path of moderation. This is Gautam Buddha's teaching. But what happens? We sometimes become very much excitable. That is known as mania. And what happens in mania? We know that we have elevated mood elevation. We are excessive talkative, excessive laughing, excessive cheerfulness, more than required. Elevated activity, you becomes very energetic and you give self-importance to you. That yes, I am the boss, like South Indian movies. Self-important ideas come. Okay. Now opposite is your depression. Okay, so totally opposite, sad mood. And because of sad mood, will you give self-importance? No. You will say, I am useless or helpless. I am worthless. Yes, sometimes we feel. And I am hopeless. Nothing can happen. And better to die. Okay? Okay? So this is mood. Now what is the hypothesis of mood? We already know that in mania there is increase in level of BDNF, and in depression there is decrease in level of BDNF. What mood stabilizers will do? The drugs which we use in bipolar disorder are known as mood stabilizers. They bring everything back to normal. They bring everything back to the normal. They reduce BDNF if it is very high. They increase BDNF it is very low. So they stabilize everything. So I will tell you that mood stabilizers are the drug which are used for the treatment of bipolar disorder. So for the treatment you give mood stabilizers. Okay, but before going further, I want to tell you that BPD is of two types. This is given in your pharma books also, so that is why I am telling you. BPD is of two types: bipolar disorder 1, bipolar disorder 2. In BPD 1, patient presents like this: full attack of mania. In BPD 2, person presents like this: hypomania with major depression. Okay, so in BPD 1, patient is having mania, and in BPD 2, patient has hypomania with depression. So can we say that BPD 2 is depression predominant mania? Here more depression is seen. So BPD 1 more mania is seen. In BPD 2 more depression is seen. Okay. So remember this part. Okay. Let's talk about the drugs for bipolar disorder. So the drugs for bipolar disorders are known as mood stabilizers. The drugs for bipolar disorder are known as mood stabilizers. Okay. And let's write a mnemonic for it. Mnemonic is low voltage. Low voltage. We will come to beta BDNF, brain derived neurotrophic factor. We will come to that BDNF shortly. L for the most famous drug, lithium. V for valproate. Or you will write di-valprox. Di-valprox. Di-valprox is two molecules of valproate combined together. Why? Better GI absorption, or you will write less GIT irritability. So we prefer to use this one. Okay, di-valprox. They both are same. You'll write oxcarbazepine or carbamazepine. Both are brother. lamotrigine, topiramate, leave A, I am leaving A, G for gabapentin. I am leaving the A word. I am telling you what the A is in a short while. Remember, apart from lithium, all these drugs, can you tell me where we have discussed all these drugs? Except from lithium, can we say all these drugs were anti-epileptic drugs? All these drugs were anti-epileptic drugs. So one is lithium, which is a mood stabilizer. Second is anti-epileptic drug. The remaining A you will write is atypical. You'll write antipsychotics. Antipsychotics are also mood stabilizers. And which antipsychotic we use? Atypical antipsychotics only. Typical we don't use. Okay. So lithium, anti-epileptic drugs and antipsychotic drugs are mood stabilizers. Easy to remember now? Okay. Mood, easy to remember. Now, among these three classes, remember this OTG. O for oxcarbazepine, topiramate, and gabapentin. You'll write, they are used in bipolar disorder, but they are not approved. If a drug is not approved, still used in a disease is known as off-label use. Okay. This OTG, in which you make chicken tikka, one guy is here also with the name chicken tikka. So in OTG we make chicken tikka, they are not approved for a moment. Okay. Okay. So this is the list of mood stabilizer. Among them, less GIT irritation. Okay. Less GIT irritation. Now, among them, we have to discuss one drug in very great detail. That is lithium. We have to discuss this drug in great detail. Other drugs we have somewhere discussed. But before coming to lithium, let's see certain management of bipolar disorder. Okay. Management of bipolar disorder. Okay. Okay. Management. So let's talk about. So treatment of bipolar disorder, after I will tell you lithium in great detail. First point you will write, if the patient presents to you with acute attack of mania, if the patient comes to you with acute attack of mania, the drug of choice is antipsychotics. Okay. In psychiatry, you will learn a word valproate, but you will write antipsychotic. The reason is it is the fastest acting drug. But other drug you can use is valproate or divalproics, lithium. So these are the drugs, and the last drug is carbamazepine. These four drugs are approved for acute attack of mania. Okay. So among them, the fastest drug is antipsychotic. We generally combine antipsychotic and valproate and give to the patient. Okay. No beta, over the counter means you don't need any prescription. Okay. Now, along with that, don't you think in a acute attack of mania, patient is very violent, very talkative? Don't you think we need to sedate a person? Let the patient sleep. Give benzodiazepine. Remember, benzodiazepines are not mood stabilizer. Benzodiazepines are given to sedate a person. Okay. This is how you will start the acute attack of mania. Done. Now the patient is absolutely fine. If the patient is now absolutely fine, now maintain the patient on. So maintenance of BPD. Drug of choice is lithium. Drug of choice is lithium. So can we say lithium is used in acute attack of mania but less preferred? And for maintenance, we give lithium. Okay. Now the point is, now you are putting the patient on lithium. Think about it. You have put the patient on lithium. Still the patient is having attacks. If still the patient is having attack, let's call this disease as. Again, the patient is having attack. Again, there is attack. Let's call it as rapid cycling BPD. It means still the patient is having rapid attacks, cyclical attacks. Then start valproate. So what is the drug of choice for rapid cycling BPD? Valproate. Rapid cycling BPD, valproate. Okay. Rapid cycling BPD, valproate. You'll write. Okay. Rapid cycling BPD, valproate. I hope you have understood. Let's talk about if a patient is having acute attack of depression. Can you tell me the treatment? In acute attack of depression, patient give ECT. Yes, add benzodiazepine with Aldra. And after that, maintain the patient on lithium. So can we say lithium is given in both depression predominant and BPD1 and BPD2? Both depression predominant as well as mania predominant. BPD beta bipolar disorder. Oh my god. So I have completed the whole story. You are asking me what is BPD. BPD is beta bipolar disorder. Okay. Okay. Let's write few points now. Then we will start lithium. Okay. Now, let's write few points now. Okay. First point. First point you will write. Okay. First is you'll write lamotrigine. Lamotrigine is only given in BPD2, that is depression predominant bipolar disorder. Lamotrigine is not given in mania. Lamotrigine is not given in mania. First question. ECT beta is electroconvulsive therapy. Okay. Electroconvulsive therapy. Electric shock, है ना? Okay. Next point. Drug of choice for resistant mania. Clozapine. Okay. Last point. BPD in pregnancy. Last point. BPD in pregnancy. Okay. Now, suppose there is a pregnant female who is taking valproate. who is taking valproate, would you stop valproate? Yes or no? Would you stop valproate? So if the female is taking a mood stabilizer, never stop. Continue with that drug. Just like epilepsy, I have told you. No. Because it will, otherwise, if you will stop, female will go into rebound mania or depression, female may commit suicide. Okay? So would you stop valproate? No. Would you stop lithium, highly teratogenic drug? No. But if the female is not on any drug, then the drug of choice in pregnancy or the safest drug in pregnancy is antipsychotics. So drug of choice for BPD in pregnancy is antipsychotic, but if the female is taking any drug, do not stop it. Continue with that. Absolutely like epilepsy. Okay? Antipsychotic. Okay? Okay? What about, so antipsychotics are mood stabilizer. What about SSRI or antidepressant? Antidepressants, you will write, they can be given for the treatment of bipolar depression. Okay, but side effect, they precipitate mania. This question comes very commonly. They precipitate mania. They precipitate mania. So tell me, are antidepressants mood stabilizer? Because of this reason, SSRI are not, antidepressants are not mood stabilizers. While antipsychotic drugs are mood stabilizer. Okay? And you will write, because of this reason, SSRI are never given as monotherapy. Monotherapy means as a single drug. They are always combined with some mood stabilizer. So remember one point, that antipsychotic drugs are mood stabilizer, but antidepressant drugs are not mood stabilizer. Okay? Antidepressants are not mood stabilizer. So we have to discuss one drug in detail that will finish our psychiatry, that is lithium. Yes, even lithium is not stopped. I will tell you this point shortly. Even valproate is not stopped. If the baby is having teratogenic abnormality, let it be. Mother is more important than baby. The life of mother is always more important than baby. Okay? If you will suddenly stop, female will go into rebound mania or depression. That will be highly dangerous. Okay? So let's discuss the last drug in psychiatry, lithium, in great detail. Very important drug for you, lithium. Even in your theory exams of second year professional in your colleges, short note on lithium comes. In Viva, lithium is asked from. Okay? Lithium is asked from. Yes, beta, SSRI are given to treat depression only. But always with some mood stabilizer. Alone you will not give. It will increase amine level, it will precipitate mania. It will precipitate mania. Okay? Let's talk about lithium. Let's talk about lithium. Uses of lithium. First, You will write uses of lithium, bhar. Uses of lithium. First, lithium is the drug of choice for bipolar disorder. BPDs, bipolar disorder. Second, lithium is used in certain headache, hypnic headache. Those headache which occurs after you go into sleep, occurs in old age very rarely, hypnic headache. Lithium is an anti-suicidal drug. If you remember, I have told you. Can you tell me another drug I have told you was an anti-suicidal drug? Which antipsychotic drug I have told you was anti-suicidal drug? Which other antipsychotic drug I have told you was anti-suicidal drug? It reduces the risk of suicide. Clozapine. Very good. You remember that part. And lastly, it can be given for resistant cases of unipolar depression as well. Okay, BPDs, bipolar disorder. These are the uses of lithium. These are the uses of lithium, bhar. Try to remember this. Anti-suicidal was a question which was asked previous year. This question was asked. Anti-suicidal drug is lithium. Another drug is clozapine. We know that part. Now, what is the mechanism of action of lithium? You'll write poorly understood. We don't know. But we will write what are the proposed mechanisms. What are the proposed mechanisms? Lithium increases BDNF level, brain derived neurotrophic factor. Lithium may also decrease brain derived neurotrophic factor. Hence, it is a mood stabilizer. Hence, it is a mood stabilizer. Do you agree with this point? Let's see. First mechanism of lithium is lithium inhibit inositol resynthesis. Lithium inhibit inositol resynthesis. Now what does it mean? Have you heard about a word inositol triphosphate? P for phosphate, I for inositol. Inositol triphosphate. This inositol triphosphate gets converted into inositol diphosphate. This gets converted into inositol monophosphate. And it gets converted into inositol. Okay, inositol. Here we have one enzyme. Here we have one enzyme, inositol monophosphatase. And this enzyme is inhibited by lithium. Remember, epinephrine, norepinephrine, serotonin, they act through inositol pathway. Okay, they act through inositol pathway. Second, this question has been asked. Second, it block sodium and potassium ion flux. If you remember your chemistry, in periodic table, we have lithium, sodium, potassium. Remember lithium, sodium, potassium? So lithium is just like a ion, like sodium and potassium. It blocks those channels. Instead of sodium entry, lithium will go inside the cell. Okay. And lastly, lithium block release of amines. Which amines? Two amines, norepinephrine and dopamine. Okay, norepinephrine, dopamine. Let's understand, let's make a diagram to remember it. Suppose this is a neuron. Entry of sodium depolarizes a neuron, and this releases norepinephrine and dopamine. Do you agree? This norepinephrine and dopamine, they act on GPCR. Now I'm explaining you. And they act through inositol pathway. They act through inositol pathway, which will increase BDNF synthesis. Okay. Now, lithium blocks ion influx, blocks release of norepinephrine and dopamine, blocks inositol pathway, hence it will decrease BDNF synthesis. This question has been asked actually. Otherwise, I wouldn't have gone in so much detail with you. Unfortunately, this question has been asked. Okay. If you want, after lithium, we will over the class. Okay. Opioids can be covered in your anesthesia also. Okay. They are used as an anesthetic. So let's continue here. Okay. I hope you have understood this diagram. Yes or no? Tell me, you have understood this diagram? The summary of this diagram? Understood the summary of this diagram? See this diagram? Understood the summary of this diagram? No. See what happens in nerve. Sodium enters. Sodium leads to depolarization. Depolarization leads to release of epinephrine, norepinephrine. They act on their receptor, GPCR receptor, through inositol pathway, which increases BDNF level. Lithium inhibit this thing. Okay. Lithium inhibits sodium influx. Lithium inhibits norepinephrine and dopamine release. Lithium inhibit inositol synthesis. Because of all this reason, the level of BDNF reduces. Okay. So I told you, mood stabilizers, they can reduce as well as they can increase the level of BDNF. Oh, sorry. Okay. So decrease the level of BDNF. Okay. Decrease the level of BDNF. Let's talk about how it increases BDNF level. Just write one point. Lithium inhibit GSK3 enzyme. Just write this point, don't have to go into detail. Glycogen synthase kinase. See, when you don't know what is the exact action of a drug, you have to learn multiple things. So this is the mechanism of action of lithium. Question is asked. Unfortunately, question is asked. Okay. Unfortunately, question is asked. Done. Let's start with now properties of lithium. GSK is glycogen synthase kinase. Okay. Let's talk about properties, side effects of lithium. Okay. So let's talk about properties of lithium. Now write, if you write very fast. So lithium. Which salt of lithium we use? Either we use lithium carbonate or lithium citrate. Carbonate is better, okay? Carbonate has less GIT irritation. Second point, what is the route of administration? Lithium can be given orally. Lithium can be given IV. Okay? Lithium can be given IV. When given orally, lithium has up to 99% oral bioavailability. Question is asked. How much lithium is absorbed when given orally? Up to 99%. Only 1% is excreted out in feces. Second point, half-life of lithium. Remember, lithium is the first metal in periodic table. Remember, half-life is 1 day or 24 hours. 24 hours. My question from you is, if remember your general pharma, remember one concept of general pharma, don't write in your notes. Remember, to achieve a effect of a drug, we require, to achieve a steady effect of a drug, we require 4 to 5 half-lives. Remember, after 5 half-life, a drug becomes constant in blood, steady state is achieved, and the effect of a drug comes after 5 half-lives. So tell me, the effect of a lithium, when you are giving oral lithium, its effect comes after? Effect of lithium comes after 5 half-life. Right, 5 to 7 days. Effect of oral lithium comes after 5 to 7 days. So my question is, if you want to produce sudden effect, you want to produce sudden effect of lithium, don't you think you should give a little bit higher dose? You should give a little bit higher dose. So you will write IV lithium in acute mania. Sorry. IV lithium in acute mania requires a little bit higher dose. That means that dose is known as loading dose. This concept we will discuss in general pharma. Lithium, if you want to produce sudden effect, you require higher dose. Yes, absolutely fine. Next point with lithium. Think lithium as a small metal just like sodium. Think lithium just like a small metal, sodium. When you eat sodium, do you think sodium gets degraded in your body? Do you think sodium will get metabolized in your body? No. Sodium is just like sodium gets excreted out in urine. So you will write lithium is just like sodium. Lithium is not metabolized in our body. It is just like sodium. Okay? Lithium is not metabolized in our body. So lithium is excreted unchanged. Unchanged. Okay? Like sodium. Because lithium and sodium are similar atoms. Tell me, maximum sodium is excreted in 99% of lithium, 95% of lithium is excreted out in, just like sodium, urine. Okay? Don't you think, like sodium, lithium will be excreted out in sweat, saliva and milk? Because sodium is also excreted out in sweat, saliva and milk. This question has been asked many times. Tell me a drug which gets excreted out in sweat, saliva, milk, tears, all body secretion. Just like sodium. that is lithium, because lithium and sodium are similar atoms. Okay, now the point is, because of this reason, you will write lithium is absolutely contraindicated in renal failure. Lithium is absolutely contraindicated in renal failure. Lithium is absolutely contraindicated during breastfeeding or lactation, because it will go to the newborn, it will be very dangerous. Lithium is absolutely not given during lactation. Either we don't give lithium, or we will tell the female mother, don't breastfeed her child. Okay, don't breastfeed her child. What is the concept of loading dose beta? We will discuss later on. In general pharma, it's a very big concept, different concept. Okay, it takes a lot of time to explain also. Okay, so lithium is contraindicated in renal failure. Lithium is absolutely contraindicated in breastfeeding and lactation. So here only. What about lithium in pregnancy? Lithium is also teratogenic drug in pregnancy. Okay, but my question is, if a female is taking lithium, would you stop lithium? Would you stop lithium? No, we will not stop lithium. So those categories of drug which are highly teratogenic, still given in pregnancy, are known as, but not stopped in pregnancy. They are known as category D drug. Very good. Some students have answered yes. Now let's see what are the teratogenic side effects of lithium. What are the teratogenic side effects of lithium? Very important, many times asked. Write a mnemonic. E, F, G, H. E, F, G, H. Okay. E for lithium causes Epstein anomaly. This question is a very important question. Epstein anomaly. Why? Epstein anomaly is a type of cardiac malformation. Tricuspid valve is not produced in this case. Tricuspid valve is malformed. Epstein anomaly is a cardiac malformation. FG, fetal goiter. And lastly, hypotonia. Let's just hypotonia. What is expected? This one. Very important. Don't forget this part, that lithium causes Epstein anomaly. You cannot afford to miss this point. If you miss this point, you can be failed also in exams. Okay, so it is important. Okay, it is important. Let's talk about now next point with lithium, that lithium is a narrow therapeutic index drug. Hence, lithium requires therapeutic drug monitoring. We continuously measure the blood levels of lithium. So what should be the blood level of lithium? We will write Okay. Blood level of lithium, you will write up to, let's say 0.6. Now this is a new update I'm telling you, to 1 milli equivalent per liter. It is given for the treatment of BPD. This is a new update. Earlier I have told you some different blood level, now change to this part. More than 1.5 milli equivalent per liter. Lithium produces toxicity. Lithium produces toxicity. More than 2 milli equivalent per liter in blood. It's an indication for admit the patient in hospital. Admit the patient in hospital, otherwise the patient will die. And more than 4.0 milli equivalent per liter, it's an indication to start hemodialysis. This is an important chart for you. Start hemodialysis. Okay. So toxicity of lithium comes after 1.5. Hemodialysis you will do after 4. Okay. So one question arises. If the patient comes to you with toxicity, but the blood level are still less than 4, how to manage lithium toxicity? How to, TDM beta means therapeutic drug monitoring. In therapeutic drug monitoring, we check the blood level of a drug. We check the blood level of a drug, therapeutic range of a drug. Okay. This is known as therapeutic drug monitoring. Okay. Okay. So therapeutic drug monitoring. So this question you have to remember. So first point, how to manage lithium toxicity. So you will write lithium toxicity. You will write do adequate hydration. Hydration is very important because dehydration or sodium loss increases PCT reabsorption of lithium, because kidney will think this is not sodium, this lithium is just like sodium, which will increase toxicity. So remember, dehydration leads to toxicity of lithium because dehydration leads to more reabsorption of lithium just like sodium. So you will give sodium bicarbonate. This is the mainstay of treatment. And now add diuretics mannitol, and second diuretic is amiloride. These two diuretics are used. No other diuretic is used. Only two diuretics. Okay? Only two diuretic. But my question is, first you will give diuretic or first you will give hydration? First always do hydration, because if first you will give diuretics, it will lead to dehydration. First giving diuretic will lead to dehydration. They will rather cause lithium toxicity. So first treatment is hydration, then add a diuretic. Very good. So let's talk about what are the adverse effect or side effect of lithium. Side effect of lithium. Sodium, sodium you have to give so that more sodium is excreted out in urine. Kidney should not reabsorb sodium or lithium. Okay. So side effect of lithium. We will do till the blood level of lithium falls below 1.5. Side effect of lithium, write a mnemonic, lithiums. Important for you. Side effect of lithium is lithiums. First one. So the mnemonic is lithiums. Let me finish beta lithium. Let me finish lithium. The side effect of lithium is lithiums. So first you will write leukocytosis. Increase in WBC. Reason not known why it occurs. Okay. Increase thirst. Reason, lithium increase osmolarity and lithium causes dehydration, which will increase in osmolarity or dehydration, stimulate our thirst center. Okay. Lithium causes tremors. Why tremors? Just like sodium, lithium will enter into muscles and muscle will become depolarized. Lithium, just like sodium, will enter into muscle. Why thirst? There is increase in osmolarity. Osmolarity increase, stimulate our thirst center. Dehydration and hyperosmolarity. Okay. Tremors. Now you will write tremors. Normal dose. Fine tremors. Toxic dose. Coarse tremors. Treatment. Propranolol. I told you propranolol is given for tremors. Treatment, propranolol. Okay. Then next point, very important, very commonly asked. Lithium causes hypothyroidism with goiter. Lithium causes hypothyroid goiter. Reason, lithium inhibit T3 and T4 release from thyroid gland. Because of this reason, there will be no negative feedback on TSH. TSH level increases and TSH causes enlargement of thyroid. Which is known as goiter. Which is known as goiter. Treatment is give T3 and T4 from outside. Like levothyroxine, etc. Okay. Okay. Next, lithium increase urination. Lithium increase urination. Why? Because lithium blocks ADH receptor on kidney. Lithium blocks ADH receptor on kidney. This disease is known as nephrogenic. That means on kidney, when ADH is not acting, it is known as diabetes insipidus. Because ADH hormone is anti-diuretic hormone. It inhibits diuresis by reabsorbing water. If ADH receptors are blocked, water will be excreted out in urine. Urine volume will increase, heavy urination. Okay. Treatment. Lithium-induced nephrogenic diabetes insipidus. Give amiloride. Li word is coming in amiloride. Which diuretic is given? Amiloride. Okay. Amiloride. Next. Lithium produces mental changes. It may lead to seizures. In extreme cases, it may lead to coma and death also. Lastly, lithium leads to skin changes. It leads to acne and psoriasis. Acne and psoriasis. Okay. See, you can give in SiADH, but the problem is lithium itself is a very toxic drug. So that is why we don't use in SiADH when the level of ADH is high. Theoretically, you can use it, but toxicity is very high. Okay. Next point with lithium. ECG changes with lithium. Question comes. Okay. Lithium inhibit SA node, which manifests as sinus bradycardia, and on ECG there is increase in RR interval. I hope you had your ECG classes in medicine. Second, why amiloride? I will tell you in amiloride only. Lithium gets reabsorbed from ENaC channels also. Lithium inhibit AV node on heart. Hence, it will delay conduction. It will increase PR interval on ECG. You know that PR interval is the interval between atria and ventricle due to AV node. Okay. Next point. Lithium reduces sodium and potassium concentration inside cell. Why? Because lithium itself will go. You know that when potassium moves out of a cell, there is T wave. When potassium moves out of a cell, there is repolarization and there is T wave which occurs in ECG. So now there is less potassium inside the cell. So it will lead to flattening of T wave. Because T wave is because of outward movement of potassium. It is flattening of T wave. Okay. So this point you have to remember. Okay. Flattening of T wave. So these are the ECG changes on lithium. Last point with the lithium is drug interaction of lithium. Drug interactions of lithium. Yes, amiloride is a drug of choice for lithium-induced nephrogenic diabetes insipidus. We have learned that. Thiazides we don't get. Thiazides causes lithium toxicity. So first point, you'll write stand. writes stand. I'll tell you the reason. S for spironolactone, one diuretic, tetracycline, ACE inhibitors, NSAIDs, and diuretics, loop and thiazides. Very commonly asked question. All these drugs stand, they increase reabsorption of lithium from kidney. Hence, all these drugs, they increase lithium toxicity, and we should not combine these drugs with lithium. Okay? Stand. Remember the word stand. Commonly asked question. All these drugs, they increase because all of them, they have a little bit diuretic action. Okay? Next, sulfonylurea. Succinylcholine, sulfonylurea, which are used in diabetes, succinylcholine, their toxicity is increased by lithium. So lithium increases their toxicity. So now it is opposite. So sulfonylurea, they will lead to hypoglycemia. With succinylcholine, there will be paralysis of muscles. Paralysis of muscles. Okay. So these are the drug interactions of lithium. Okay. These are the drug interaction of lithium. This completes a very big topic of psychiatric diseases. Okay. This completes a very big topic of psychiatric diseases. Okay. So I think we can stop here now. Opioids and anesthesia will be covered in anesthesia. And after that, we will be again having pharma. Again, we will be having pharma classes. Then we will start with anesthesia. You'll have a better understanding. Okay. You want to learn opioids. See, in 40 minutes, I will not able to teach opioid on this screen actually. If you want, I can teach. Chalo, let's start with opioid. If you are so eager, let's do it. Let's do it then. Let's talk about opioids. Let's start. If you're enjoying, I am even more enjoying with you. Okay? Let's start with opioids. Those students who don't want to attend, who are tired actually can go. Okay? If you're not understanding, you can see this video later on. But I hope I am making you understand. I hope I'm making you understand. Okay? So let's start opioid. Opioids is a simpler topic. Psychiatric diseases are a little bit tougher topic. So let's start. Let's do it. Let's do it. Okay? Chal. Next topic. Let's do it. Okay? Let's do it. Okay? Chalo. Show some energy. Okay? Because the ultimate pleasure in your life will come from these drugs only. Opioids. God's own medicine. God has made this thing for himself. Why? So pleasurable. Okay? So what is opioid? Let's understand. Opioids are the extract from opium. Opium means from poppy plant, known as Papaver somniferum.
So they are obtained from an extract of poppy plant known as opium. Okay. Now you will write from this opium. Okay. We obtain certain natural chemical. Okay. Natural opioids. Some of them have analgesic effect. What do you mean by this word analgesic? Pain reliever. Pain reliever. They are the best pain reliever. But some of them are non-analgesic. Some of them are not analgesic. Some are pain relieving, some are not pain relieving. So among analgesic, which chemical is found in nature? Morphine and codeine. Okay, and they are primarily used as a painkiller. Next point, not cocaine. Beta, cocaine is from some different plant. Erythroxylone coca. Non-analgesic, you will write noscapine and papaverine. You can write one more drug, but nobody will ask you thebaine. Okay, thebaine. Now the point is, we will discuss these drugs in very great detail. What about this noscapine and papaverine? You'll write noscapine is given as an antitussive agent. It is not a painkiller. Antitussive means it will suppress cough symptoms. They are given for the treatment of dry cough. Antitussive means dry cough. Papaverine is a vasodilator. Okay, it's a phosphodiesterase inhibitor. Because of this reason, it is given for the treatment of impotence. So they are not used as a painkiller. Okay, they are not a painkiller. So what are painkiller? Morphine and codeine. Now let's focus on this painkillers only. We have to focus on this analgesics only. Before starting analgesic, write natural opioids. They are also known as opiates. Natural opioids are also opiates, but now we have certain synthetic opioids as well. Now we have synthetic opioids as well as a drug. Now we have made synthetic drug as well. Okay. Now let's start first point. Before starting drug, what is the effect of opioid in our body? What is the effect of opioid in our body? If you understand the effect, drugs are very simple. Okay, the effects of opioids in our body are because of opioid receptors which are present in our body. Our body has opioid receptors. Okay, our body has opioid receptors, and opioid receptors are of which type? GPCR. GPCR is G protein coupled receptors. Let's talk about opioid receptors. Now this is a very important part. Opioid receptors. Okay. See, the student who are not willing, if you have a little bit tired, you are feeling tired, you can take a break. Okay, but there are students who are eager to learn. Let them learn. Okay, opioid receptors. Now there are three main opioid receptors you have to remember. Mu. I will use the short form of mu like this symbol. Kappa. And delta. These are the three main opioid receptor you have to remember. Okay. There is a fourth opioid receptor recently we have known that you don't have to remember. That recent fourth receptor which we have found is orphanin FQ. Okay. There is no importance of this fourth receptor, so we will not discuss this fourth receptor. Second point, does our body endogenously produce opioid? The answer is yes. Inside our body also opioids are produced which act on these receptors. So first point, what are the endogenous opioids which are produced in our body? Mu, right? Endorphin or endomorphine. Endorphin or endomorphine. Kappa, you will write dynorphin. Delta, enkephalins. There are two types of enkephalins. You don't have to go. Leucine, cysteine, you don't have to go into that detail. So these are the endogenous opioids produced in our body. You have to remember their name. Now, can you tell me, by predicting this part, morphine will be acting on which receptor? Morphine will be acting on which receptor? Make a guess. Morphine will be acting on which receptor in our body? If you are giving a morphine from outside, you are seeing morphine word is coming. I will tell you later on. Morphine will be acting on mu receptor. Okay, that is a question. Let's see, if you stimulate this receptor, what will happen? Effect. If you will stimulate this receptor, what will happen? Write a mnemonic. Sacrum, sacrum, okay, sacrum, gap, GAPH, gap, sorry, yeah, sacrum, gap. Okay. First point, mu receptor. I am talking about mu receptor right now. First point, S for sedation. A for analgesia. That means pain reliever. Okay, pain reliever. You will write constipation, because in GIT they reduce motility of our GIT. And cough suppression. They suppress cough centers of our brain. So these centers of our brain will suppress. Death is because of respiratory depression. Death is because of respiratory depression. They suppress respiratory centers in our brain. U for, you will write euphoria. Euphoria means blissful state. Person will be so blissful that they are highly addictive drug. Because of euphoric feeling, they are highly addictive drug. They produce meiosis or pinpoint pupil. Why? Instead of suppressing, they stimulate one center of our brain. They stimulate Edinger-Westphal nucleus. You know, oculomotor nerve arises from there, which causes meiosis. They stimulate Edinger-Westphal nucleus. Very good. Now, just write, I will tell you later on why it occurs. They cause gallstones. You'll write, they cause abdominal colicky pain because they cause spasm of sphincter. They cause spasm of GIT sphincters. Can we say sphincter will be spasm? Let's say this is a gallbladder. This is cystic duct. You know, below that there is sphincter of Oddi. Sphincter of Oddi complex is there. If all these sphincters will be contracted, can we say bile will not flow? If bile will not flow, it will lead to gallstones. And spasm of sphincters leads to colicky pain. Yes, we discussed that part in ANS also. Okay, so let's talk about further. They cause prolactin increase from high pituitary. And they cause hypotension. Why? Because they suppress vasomotor center in our brain. They cause hypotension because they suppress vasomotor center in our brain. So vasodilatation will occur. So this is a mnemonic commonly asked. Okay? Yes, Shishir Das, we will come to that point. So if I'll ask you one question, opioids are given in all type of pain except which pain? I will tell you this question. Opioids are given in all type of pain except colicky pain. Yes, absolutely right. Before coming to that point, let's talk about kappa receptor and mu receptor. Kappa receptor and mu receptor. Kappa receptor, we will write, in kappa receptor, everything is same like mu. In kappa receptor, everything is same like mu receptor except two things. First point, instead of euphoria, you will write, they produce dysphoria. Kappa receptor produces dysphoria, that means increase in psychosis. And they cause diuresis. Why diuresis? Because they decrease ADH secretion. Okay? Okay? So kappa receptor instead of euphoria rather produces dysphoria. This question has been asked many times, that which receptor of opioid produces dysphoric or psychotic symptoms? Answer is kappa receptor. Kappa receptor causes dysphoric or psychotic symptoms. Okay, class is still 3 or 3:15. Okay, we'll finish opioids, don't worry about that. Done. Let's talk about delta receptor. Let's talk about delta receptor. Delta receptors, we will write, delta receptor, we will write same thing. Okay, same thing, but you will write first analgesia and you will write supraspinal and affective analgesia. What do you mean by affective? Don't you think when you have pain, you cry, you have emotional challenges with pain? When we have pain, pain has a disturbing feeling. Why affective? Because it will improve the affect means emotional component of pain. It will improve the emotional component of pain. Okay? Okay. Next point, analgesia, they cause constipation. Yes. They cause respiratory depression. Same, everything same. But the last point is, which opioid receptor produces convulsions? Which opioid receptor produces convulsions? That is delta receptor. That is why we don't have any drug among opioid which act on delta receptor. Which receptor of opioid produces convulsions? Delta. Okay. Which opioid receptor produces delta? बनी भैया मेरे पास है फोन, थोड़ी देर में कॉल करता हूँ मैं आपको, मेरी क्लास चल रही है, आप रिंकी भाभी के फोन पे कर लो. ओके. Now, I'm sorry, somebody was calling me. Okay. Done. Let's talk about now. Let's talk about first point. First point, analgesia. Only one point I will tell you. You'll write all opioids. They are the best or most effective painkillers. They are the best and most effective painkillers. Hence, they are the drug of choice. Let's write the reason why. Why they are the best or the most effective pain reliever? Because they act at spinal level. They act at supraspinal level also. Okay, they act at spinal level of pain sensation, supraspinal level also. In spinal level, the site of action is they act on an area of spinal cord known as substantia. Remember your physiology. Gelatinosa. Substantia gelatinosa has opioid receptor. Substantia gelatinosa has pain receptors. So let's write, as they are the best pain reliever, opioids, they are given in severe pain. Drug of choice is opioids. Okay. For mild pain, give NSAIDs. For mild pain, give NSAIDs. Okay. Can you tell me certain causes of very severe pain? Okay. The causes of very severe pain, like example, cancer pain, crush injury. These are very severe pain. Fractures. You know the pain of a fracture is very severe. Post-operative analgesia. After operation, you have torn a patient. Here, everywhere drug of choice is opioids. Everywhere drug of choice. If a patient is having severe pain, give. But opioids are not given in. Colicky pain. Because they themselves cause them. So opioids, they are not given in colicky pain. Remember, in emergency, if a person comes to you with abdominal pain, sir पेट में दर्द हो रहा है, never give opioid. Okay, never give opioid. Done. Let's write about now drugs. Let's write about now drugs. Opioids as a drug are of two types. First, morphine-like drugs. Morphine and congeners, because they act on which receptor? Mu receptors. Next is mixed acting opioids. Why mixed acting opioids? Because they act on mu kappa delta receptors. Mixed acting opioids, they act on all receptors. Okay, so first is morphine and its congeners. Next is mixed acting opioids. Done. Then let's talk about morphine and congeners. First drug, morphine. Morphine, you will write, it is a prototype drug. Prototype drug means all other drugs are compared with morphine. Morphine is taken as a standard. Okay, and morphine is a full agonist at mu receptor. Prototype means morphine is taken as a standard. Okay, let's talk about now morphine. Okay, root, all root, but except, you will write intranasal. Morphine is not given intranasal. Which is the only opioid given intranasal? Only opioid which is given intranasal is butarphenol, which I will be telling you shortly. Okay. Avoid morphine intrathecal. Why? Intrathecal morphine leads to hypotension. Can you tell me why? Why intrathecal morphine will lead to hypotension? It will suppress which centers? It will suppress which centers? Vasomotor centers. Okay. Intranasal, drug addict, they take intranasally. Intense pleasure. Person will say, why should take morphine as a drug? Bring morphine, let's have a party. That is why we don't make intranasal preparation. Okay. Okay, we'll come to everything. Don't worry about that. Okay. Yes, vasomotor center. Yes, it suppresses vasomotor center. That is why. Don't give hypointra. Let's talk about now. Properties of morphine. First, morphine, its active form, it gets converted into two active form. One is morphine 6-glucuronide. This question comes. Second is morphine 3-glucuronide. One is morphine 6-glucuronide. Second is 3-glucuronide. 6 is a bigger word. It is the major active form. And it produces analgesia. 3, it is minor form. And it is mainly produced in children, and it leads to seizures. 3 is mainly produced in children, and it leads to seizures or convulsions. Okay. Morphine 3 is a minor form, mainly produced in minor children. It leads to seizure. So this is a bad form of morphine. Okay. Okay. Done. Now, second point. Morphine is a basic drug. Morphine is a basic drug. Now remember one point. Any basic drug in our body, remember this is mast cell. Don't write this diagram, I'm just explaining you. In our mast cell we have heparin. And in heparin, don't write this diagram, we have histamine. Okay. Heparin is acidic, histamine is basic. Okay. Heparin is acidic, histamine is basic. Remember, if you give any basic drug from outside, that basic drug can bind to heparin. Histamine will become free and histamine will be released. Histamine will become free and histamine will be released. So remember, basic drugs, they release histamine from mast cell. So you will write morphine, release histamine. Basic drugs, they release histamine from mast cell. Morphine releases histamine from mast cell. All basic drugs can release histamine from the mast cell. Hence, morphine causes side effect, asthma, and intense pruritus. Drug abusers who take morphine, intense pruritus occurs. Okay? Because it releases histamine from the mast cell. If I'll ask you certain question, sir, vancomycin is also a basic drug. Vancomycin is also a basic drug. Vancomycin also releases histamine. Hence, vancomycin causes red man syndrome. What is red man syndrome? Vasodilatation will occur on skin. Because vancomycin is also a basic drug. Morphine is also a basic drug. Basic drugs, they release histamine from the mast cell because they bind to acidic heparin. Histamine will become free, it will be released. Okay? So that point I will tell you later on. Third point, we will write. Third point with morphine. You will write that all opioids, including morphine, all opioids, including morphine, are absolutely contraindicated in head injury. Pain of head injury, don't give opioids. Let's understand the question. Okay, let's understand the question. Sir, what happens? Why we don't give opioids in head injury? Let's see the reason. Because opioids, reason, we will write reason, very commonly asked. Because opioids, they will suppress respiratory centers. Opioids, they suppress respiratory centers. Because of this reason, there will be decreased ventilation. Decrease in ventilation will cause increased CO2 in the body. Increase in CO2 causes vasodilation in brain. And vasodilatation increases CSF formation. CSF formation will increase ICP. What is ICP? ICP is intracranial pressure, which will put more pressure on the brain. In head injury, already because of bleeding, there is more pressure on the brain. Now even the pressure inside the brain will increase, medulla will get compressed and the person may die. Okay. One question of medicine. If a patient of increased intracranial pressure comes to you, what you will tell to your patient? Hypoventilate or hyperventilate? Remember, in treatment of intracranial pressure, we tell the patient to hyperventilate. And I hope now you know the reason why. In increased intracranial pressure, when the pressure is increased, tell the patient to hyperventilate. This is the treatment we give. Opioids, they cause suppression of respiratory centers. Okay? In treatment of ICP, we do. Now, in head injury patient, we assess the head injury by a scale, Glasgow Coma Scale. There is a scale known as Glasgow Coma Scale. Glasgow Coma Scale is a method of assessment of head injury. In Glasgow Coma Scale, we give painful stimulus to the patient and we see the response of the patient. Opioids, they reduce pain sensation, the person will not respond. So it interferes with Glasgow Coma assessment. Second reason, we don't give in head injury because the person will not respond to painful stimulus. Two reasons why opioid should not be given in head injury. First, they increase intracranial pressure. Second, they interfere with Glasgow Coma assessment. Okay. Now you will find one MCQ. Which of the following is an absolute contraindication of using morphine? Is it asthma or is it head injury? Morphine should not be used in asthma and head injury. You will go by the answer head injury, not asthma. Head injury is a contraindication of morphine. In asthma, we can give morphine. Okay? If there is some dangerous disease, even in asthma, you can give morphine. But in head injury, never give morphine. Okay? Never give morphine. Head injury is an absolute contraindication, not asthma. Okay? Glasgow Coma Scale you will learn in medicine. Okay? Let's talk about uses of morphine. Uses of morphine. First use, as an analgesic. You'll write all opioids are used as an analgesic. All opioids as an analgesic. Second use, morphine is the drug of choice for MI, myocardial infarction. Why? Because morphine causes bradycardia. Morphine causes bradycardia, decrease in heart rate. Decrease in heart rate will decrease oxygen demand of the heart. and it has cardioprotective effect. It has cardioprotective effect. Okay. So this is the reason. This is the reason. Now, there are two opioids which are absolutely contraindicated in MI. You will write pethidine and pentazocine. Why? Because pethidine and pentazocine they produce tachycardia. Pethidine and pentazocine, I will tell you the reason why later on they cause tachycardia. Okay. Even in inferior wall MI, sometimes you can use it, but generally we don't use. Generally we avoid it. It would be very dangerous to use. You can use an inferior wall MI, but that is not a question you must remember. Okay. Next point. Morphine is also used in treatment of acute left ventricular failure. Acute left ventricular failure. Suppose this is heart, this is left ventricle. If left ventricle is failed, can we say the blood will be collected in lungs? The blood will be collected in lungs. It is also known as acute pulmonary edema. Because in acute left ventricular failure, the blood will be collected in lungs and the person will have dyspnea because of acute pulmonary edema. So here only, I will tell you the treatment of acute pulmonary edema. Sir, the treatment of acute pulmonary edema is, you know, this is the right part of the heart and the blood which goes from the right part of the heart goes to lungs and it goes through veins. Remember, in acute pulmonary edema, the treatment, why we give? Because we reduce preload. We reduce preload or we will produce venodilation. This is the treatment of acute left ventricular failure. Remember, in left ventricular failure or pulmonary edema, we reduce the blood supply of right part of the heart. Okay? We reduce the blood supply of right part of the heart so that excess of blood should not go to the lungs. Okay? And for this, why we give morphine? Because morphine causes hypotension. Morphine suppresses vasomotor center. What is the treatment of acute LVF? You will write the treatment of acute LVF is LMNOP. The treatment of acute left ventricular failure is LMNOP. Okay. L for the drug of choice is loop diuretics. Why? Because loop diuretic, they increase prostaglandin production. Prostaglandin causes venodilation. Prostaglandin production causes venodilation. Drug of choice for acute left ventricular failure is, or acute pulmonary edema is loop diuretic. Second drug, morphine. Morphine produces venodilatation because it suppresses vasomotor center. Nitroglycerine. Nitroglycerine. Nitroglycerine produces nitric oxide, causes venodilation. Give oxygen to the patient. Look, give oxygen to the patient. And the last point is, you will tell the patient to Keep on sitting. Do not lie down. Do not lie down means tell the patient to remain in proper position, sitting posture. Because if the patient will lie down, the venous blood of the legs will easily reach to the heart. This is the treatment of LMNOP. Okay, LMNOP. This is the treatment of acute left ventricular failure. This question you will get in your exams. Is morphine used in acute left ventricular failure? Yes. Okay, because it's a venodilator. Okay, it's a venodilator. Done? Okay, so I think it's already 3. Don't worry. You have another class also. Majority of things I have already told you. So I know I don't want to take your time. So what we can do, the majority of opioid part we have already discussed. We shall end our lecture here. Okay. So we shall end our lecture here. So it's been a beautiful journey of 15 days with you. And as a student, I am seeing on Facebook that you have given a lot of love and lot of respect to me. And as a doctor, it is the greatest inspiration for me what you have given. And I am really grateful that you enjoyed this journey of pharmacology of 15 days with me. We learned everything conceptually. Some things were tough, some things were easy. That happens with each one of us. It happens with each one of them. In first go, we cannot remember each and everything. Okay? But as a teacher, I am really overwhelmed that this 15 days were really enjoyable. Otherwise, this lockdown would have been a very, very depressing environment it was creating. So as a teacher, only I can give you my blessings. Okay? Always be very mad to learn new things. Always be mad to learn new things. Always have unshaken belief. Always have unsatiable desire to learn new things. Always be a student in your life. Even if you are at age of 60 years or 70 years, learn new things. Okay? Keep reading and revising. Because at one point, I know right now your journey has been started, but at one point, all these things which you are learning today will come to a point of singularity. Just like our Big Bang, every knowledge in your brain will make sense to you at one point later on. It will come to a point of singularity. It will become like a musical rhyme. You can explain each and everything conceptually in one go later on. It takes time. Okay? It takes time. Okay? So everything will come to a point of singularity. Apply all your knowledge, apply all your skills only for one purpose. Serve this mankind, serve this society only. And most of all, serve your patient with noble intention. Okay? Remember, many students ask me which field has more money. Remember, money is boring. At one point, money is really boring. Have an ultimate goal in your life. That ultimate goal is apply all your knowledge for the society. Okay? So this is all I can give you as a teacher, as my wisdom. As my wisdom, the only thing I can give you is this one. And as a student, I expect that you will learn all subjects conceptually. You will not cram as much as possible. Avoid cramming things. But there are things we have to cram actually. Cramming is also sometimes important. Okay? So I think we shall end our lecture here. I'm really grateful. I'm really thankful. So let's end our lecture here. If you have any doubt, you can ask me. If you have any doubt, you can ask me on club. We will do a small test also. A test will be conducted. Okay, a test will be conducted. Don't worry. And that test will be conducted. I will prepare a test for ANS and CNS. Don't worry about that. It will be provided to you, and I will make an exclusive test for you according to, and I will keep the questions really very hard. Okay, very hard questions, extremely hard difficulty level of test I will make for you. Okay, and do that test, and if possible we will discuss the questions of that test also by coming live on Facebook. Okay, so thank you very much. It's been a grateful journey of 15 days, and now I expect that you should love other subjects like you have loved pharma. Okay, so like you have the pharma, so thank you very much. You can tag me on your club. Okay, regarding opioids, I'll try to upload a video of opioids. Regarding opioids, I'll try my best to upload a video of opioid in this coming 4-5 days period. Let's see how technicalities will work out. Okay, if there is no technical problem, I'll post a video on opioids. Okay. Okay. No, actually technical team requires a little bit time to adjust for the next faculty, to make preparations for the next faculty. So we cannot encroach on other faculties also. Okay. So thank you very much. Keep learning, keep reading multiple things, different things, and only very few part of 15-20 minutes opioid is left, but we will cover it. We will cover it. Don't worry about that. Don't worry. I'm there. Don't worry. Okay. So thank you very much. So Bella Siao. Okay. So